Hello and welcome to today's Viral Hepatitis Quality Measures Technical Consultation meeting. Let's begin. Next slide. My name is Jessica Darren. I am the Viral Hepatitis Policy Advisor with the Office of Infectious Disease and HIV/AIDS Policy, or OIDP, in the Office of the Assistant Secretary for Health. I want to start off by sharing that we're really looking forward to today's meeting to hear from all of you, to hear from our panelists, to understand what states are currently doing in viral hepatitis quality measurement, to inform where we can go in the future. I also want to start off and thank Clinovations, Government and Health for their support in coordinating today's meeting. Next slide. So let's first talk about why we are all here today. Rates of acute hepatitis C doubled from 2013 to 2020. There are an estimated 3.5 million or more people living with hepatitis B and hepatitis C. These are just estimates because we all know that there are so many more who are unaware of their infection, which is why we now have universal screening recommendations for both hepatitis B and hepatitis C. Severe negative health consequences such as liver cancer, cirrhosis, and early death can occur if viral hepatitis is not identified and treated early in the course of infection. Because of these severe consequences, universal screening has been found to be cost-effective and cost-saving. Next slide. For those of you who may not be aware of OIDP, our mission is to provide strategic leadership and management while encouraging collaboration, coordination, and innovation among federal agencies and stakeholders to reduce the burden of infectious diseases. Next slide. OIDP led development of the Viral Hepatitis National Strategic Plan through coordination and collaboration with federal and non-federal stakeholders. The plan was released in 2021 and provides a roadmap to eliminate viral hepatitis as a public health threat by 2030. Next slide. A range of partners and tools are needed to address the stalled progress in reaching our elimination goals, and quality measures are one of those tools that can help us reach those elimination goals. Organizations can use quality measures to assess provider performance or as a benchmarking mechanism in payer programs. They are critical in translating clinical guidelines into practice and identifying gaps in patient care. Quality measures also serve a role in translating public health recommendations into clinical practice and enlisting healthcare providers to increase screening, treatment, and care. Next slide. So let's start our work together by understanding what partners are here with us today. Please take about 20 seconds to provide a response that best reflects your day-to-day, as we know some of these may overlap for some of you. Thank you. Let's see those results. Looks like we have strong representation from state public health with 43%, federal government with 15%, and Medicaid agencies with 12%. Thanks so much for being here today. Next slide. Now let's move to our second poll. This one is designed for practicing clinicians. Please share if your practice has any viral hepatitis quality measures. Thanks so much. Now let's see those results. Well, it's good to see that there are some practices that have both hepatitis B and hepatitis C quality measures, but not that many. So this emphasizes why we are all here today. Next slide. So the objective for today's meeting is to convene state leaders and stakeholders in viral hepatitis quality measurement to obtain feedback on the feasibility of testing and implementing a measure at the state level. This will inform OIDP efforts to advance viral hepatitis quality measurement by states and territories. Following the meeting and in the coming months and years, OIDP will use your feedback to guide our efforts to advance viral hepatitis quality measurement. Next slide. Here is today's agenda. We will hear opening remarks from CMS and CDC. We'll have a session providing background on the landscape of viral hepatitis quality measures. Dr. Sue Wong and Dr. Christian Ramers will share their perspective as clinicians who provide viral hepatitis services and weigh in on how viral hepatitis quality measures impacts how they provide care. Next slide. Then we'll have a 10-minute break. And following the break, there will be a panel discussion with 5 states, Louisiana, Michigan, New York, Pennsylvania, and Washington. Will share their state's experience with quality measures. The panel discussions will be divided into 2 sessions. The first one really hearing from the state's perspectives on how they selected their quality measures, how they tested and implemented them. And then the second session will go into recommendations for a measure that we can adopt across states and territories. And we'll also have an opportunity to hear from you outside of the panelists during that session. Then we'll conclude the meeting with a voting exercise or measure ranking to gather your direct feedback on the types of measures you value and believe are feasible to report across states and territories. Your input during the measure ranking is really important to help inform our work that we will be moving forward with at OIDP. We want to understand your measurement priorities to guide OIDP's work to advance quality measurement by states and territories. Next slide. So now I would like to welcome 2 of my colleagues, Dr. Deirdre Stockman and Dr. Nathan Furukawa. Dr. Stockman is the director of the Division of Quality and Health Outcomes in the Centers for Medicaid and CHIP Services at the Center for Medicare and Medicaid Services. And Dr. Furukawa is the Senior Advisor for Hepatitis C Elimination, Division of Viral Hepatitis at the Centers for Disease Control and Prevention. Thanks so much. Deirdre, I think you're on mute.
Whoops, sorry about that. Thanks so much, Jessica. Good morning, everybody. And thank you. It's really great to be here with all of you, and I appreciate you coming together to discuss how we might address the gaps in quality measurement for viral hepatitis. I know most of you are here today because you have a passion for improving healthcare and outcomes for individuals living with hepatitis. You want to fill gaps in care, get individuals screened, tested, and treated in a timely, respectful, and person-centered way. And that's a really important task. And quality measures, as Jessica said, are important tools, valuable tools for that task. And as you embark on it, or on some of the next steps that we'll cover today, I thought I'd just share a few reflections and considerations that might help us get to meaningful, usable measures in this space, including measures that could potentially be applicable to the Medicaid and CHIP populations addressed by the adult core set. And I was reflecting on some of the pitfalls or limitations. One thing that I think we all see in the quality measurement field is there are thousands and thousands of measures and often not the right one for the job we're looking for. And so I was thinking about why might that be and what can we do to make sure that the measures that you all help us develop are the measures we're looking for. So a few things to think about and try to avoid. So one is specifications that are too narrow with respect to setting provider levels or populations. I think what we sometimes need really targeted measures. Measures that are too narrowly specified or developed with only a small set of providers or settings or populations in mind often turn out not to be applicable in other settings. And then we get to that situation where it's like, oh, there's this measure, but it's not quite the right one for me or for my setting. So to really be thinking about, starting with the end in mind, and how do we make sure to develop measures in a way that is going to be broadly applicable to a number of settings and providers and populations. Another pitfall, and one that we're very guilty of in the federal government, is measures that are developed and driven by program funding rather than the health system need. We really want more measures, and we acknowledge this and are trying to move beyond it, right? So that we can get to more measures that work across programs, because that allows us to advance the very strongly held principle across all of us throughout the healthcare system of increasing alignment across measures and reducing duplication, or worse, sending mixed signals with different measures that are applying maybe to the same providers or settings, but for different programs. We think there's a lot of talk about the value and preference for measures that are more outcome focused. I like to think about outcomes as well as really meaningful and actionable process measures. Sometimes an outcome measure is possible, and when so, it is often ideal. But for quality improvement, and again, thinking about what we're trying to do, which is improve care and outcomes for people with hepatitis or at risk, is sometimes we need meaningful indicators of whether the steps in the process that lead to those best outcomes are happening. So, outcomes and or really meaningful and meaty and actionable process measures. And the fourth thing I was thinking about, and I know you all are as well, is the shift in quality measurement in the whole field that's happening right now to using more electronic clinical data. We're very much in the midst of that shift because there's such rich information and data in a lot of clinical sources that go beyond administrative claims. And where there's a real tension between two, and always has been, between the two desirable, I think, elements of quality measurement. One is that it should be as easy to collect and report as possible, right? Minimizing the burden across whoever the reporting burden is on throughout the system. But there's a tension sometimes between that ease of reporting or collecting the data and the really meaningful data that gives us information that's actionable and can help drive towards quality and outcome improvement. So I acknowledge, particularly in the space of electronic clinical data, where those two forces are very much in tension, particularly when it comes to measures that can be applicable at the state level, right? States are still working on figuring out how do we get a handle on all those different electronic clinical flows to be able to bring measures up to a state level. We're in the midst of that. I acknowledge that there's a lot of unanswered questions, but I think any measure being developed now needs to be thinking about and sort of skating to where the puck is going and thinking about how to best mobilize and use electronic clinical data. So finally, I know that there's a lot of interest in developing a measure or measures that could be applicable for the Medicaid and CHIP or the Medicaid adult core set of quality measures for our 40 or so million individuals who are enrolled in Medicaid, and really appreciate everyone's focus on that population. And at the same time, given the points I just made, want to make sure that the group is thinking of inclusive of Medicaid populations, but probably doesn't make sense to be limited in that space, given that folks' healthcare coverage changes over time. We want measures that are ideally applicable across settings, and to be really thoughtful about that. And be mindful, of course, as I think you already are, and this meeting is really set up to be thinking about what can get us to measures that are reportable at the state level, which is, of course, a requirement for a Medicaid and CHIP core set measure that has been tested and shown to be reportable and doable and meaningful, high quality, consistent data at a state level. And so, and finally, just want to note that any measure that goes on the core set goes through a broad stakeholder process of consideration and deliberation. That is an open and public process, which everyone is invited to participate in the various different ways. And so there are no guarantees. CMS doesn't just put measures on the core set. There is a process of engagement that in order to make sure that we are representing all of our partner and stakeholder interests and needs in making decisions on changes. So as any measure, if you know, measures that come out of this would have to go through that process. So I probably talked too long. I just want to say that, you know, the goal of this group is to develop some quality measures and to remember that the quality measure is not actually the end we seek, right? It's a tool. We seek to improve care and outcomes for people with hepatitis, and we need to develop a measure or measures that will help us achieve that goal. And I think it's really important and exciting work, and thank you all for coming to do it.
Thanks so much, Deirdre, for those reflections. Next, we'll welcome Dr. Furukawa from CDC.
Hi, thanks. Can I get the next slide? Oh, can I get my next slides? Or there we go. So greetings, everyone. Thanks for those wonderful comments, Deirdre. I think I'll follow them up by providing a perspective of how we at CDC think about quality measures and their potential for increasing uptake of our recommendations for viral hepatitis. Next slide. So just to start, this audience is probably well aware, but in case not, you know, in the past 4 years, CDC has updated really all of our guidance around hepatitis B and C, starting in 2020 with our 2020 HCV screening and testing guidelines, moving into 2022 where we updated our hepatitis B vaccination guidelines, and then in 2023 where we updated both our hepatitis B screening and testing guidelines as well as our perinatal hepatitis C testing guidelines. Next slide. I'll just go over those each in brief. So in 2020, CDC recommended universal adult screening for hepatitis C screening during each pregnancy, and then interval ongoing testing for people who have ongoing risk. Next slide. The updates in the 2022 hepatitis B vaccination guidelines were that now all adults age 19 to 59 years and then adults age 60 or greater with risk factors should receive hepatitis B vaccines. And then adults greater than or equal to 60 without known risk factors may receive hepatitis B vaccination. Next slide. In 2003, the hepatitis B screening and testing recommendations had a new recommendation for now that all adults aged 18 or greater years of age should receive at least one time lifetime testing. Testing is available to anyone who requests it, and then specifically to use a 3-panel test that includes hepatitis B surface antigen, anti-hepatitis B surface antibody, and then total anti-hepatitis B core antibody. And then it reiterated the prior recommendations of screening during each pregnancy, testing anyone who has a history of risk factors, and then periodic testing for susceptible persons with ongoing risk. Next slide. And then lastly, in 2023, we also updated our perinatal hepatitis C guidelines to recommend that all babies exposed during pregnancy to hepatitis C may receive a hepatitis C RNA test between the ages of 2 to 6 months. Next slide. So, you know, we can develop these recommendations, but its translation into clinical practice is always a bit of a bumpy road. And in reality, it can take years, sometimes decades, for these recommendations to be fully adopted. And here's just a picture of a typical adoption innovation curve where in the beginning, you have those early innovators who quickly adopt a new recommendation. And we think of those as like people who might be researchers or themselves developing some of the guidance and the evidence. As it shifts into early adopters, we can think of like our specialists who are more up to date with the literature and more likely to quickly identify updates and recommendations and adopt those recommendations. But really, the challenge is to get into the majority, where here we think about general practitioners, people day to day who aren't going to be reviewing or keeping the most up to date on all these recommendations coming out. And that challenge to get to that early and late majority of folks is probably where that biggest lag occurs. And the goal here, of course, is how do we compress the time frame of adoption by the majority? Next slide. So a good example of this is, despite a very increasingly favorable landscape for both hepatitis C testing and treatment, there's a lot of significant gaps that remain. This is an example of our hepatitis C viral clearance cascade from 2013 to 2022 data. And it uses Quest data and identifies people who have ever been infected as defined by having a positive antibody for hepatitis C, those who had received hepatitis C RNA testing or viral testing, those that were diagnosed with the initial infection, and then of those, how many were cured or cleared. And as you can see, there's significant gaps in terms of people who have incomplete testing, as evidenced by that viral testing gap, red arrow, and then people who are not yet virally cleared, as evidenced by this viral clearance gap that we hope would be greater than 80, but is only 34%. Next slide. So quality measures we've thought of as a way to potentially increase that uptake of recommended viral hepatitis interventions. And we'll give one example, which is the Merit-Based Incentive Payment System, or MIPS, and the MIPS value pathways. So the MIPS program improves reimbursement for Medicare B services, covered services and providers who improve patient care quality and outcomes. So CDC and CMS previously collaborated to include the adult one-time HCV screening measure into the wellness MIPS value pathway. And so this allows primary care providers to select this measure from among a list of them to meet some of the MIPS program requirements. There's also 3 hepatitis C measures that are a part of the infectious disease MIPS value pathway. And these have just being implemented, and so we hope that it might help move the needle to increase adoption of our one-time universal hep C screening measure. Next slide. And since this is a pretty Medicaid-heavy audience, this is just a quick reminder that Medicaid covers a substantial portion of people with hepatitis B and hepatitis C, and these are estimates from the NHANES survey based upon identification of people with prevalent hepatitis B or hepatitis C, and then we can identify which proportion of them have public insurance. In this case, we aren't able to further stratify by Medicare, Medicaid, Medigap, CHIP, etc. But just looking at it broadly, you can see for hepatitis B, about 33% of people with hepatitis B have public insurance. And then for hepatitis C, it's as many as about 60%. So this is a very really relevant, important conversation. Next slide. So we really look forward to hearing about state approaches to viral hepatitis quality measure implementation. And so look forward to that discussion and glad to be a part of it. Thanks.
Thanks so much, Nate and Deirdre, for your remarks. Now we will move to viral hepatitis quality measures and measurement landscape from Edna Boone.
Thank you, and good afternoon, everyone. I am the Clinical Quality Improvement Lead at Consultation.gov Health, and we've heard a little bit about this, but we're going to pull back for a moment and look at how quality measures fit into the larger context of clinical quality improvement. So similar to the standard, traditional process improvement cycles, we see a cycle around quality improvement, and it is very iterative. So starting up at the top with some data, we get data from research, from payers, from public health surveillance, as noted, also directly from electronic clinical records. And this tells us what's happening in the field. And based on that, we then develop clinical practice guidelines, again, to improve care. So the guidelines provide some roadmaps on what clinical care and intervention should happen for any given ailment. Next, we have clinical decision support, and these tools are created and developed to help comply with the guidelines. So these can be triggers within an EHR, they could be checklists or protocols to support clinical care. For hepatitis, this could be anything that cues an initiation of a treatment, perhaps based on the results of a positive screening test. So today, we want to advance, I think, our automation on this slide. We're really focusing again on the measurement and the reporting, essentially telling us how well we are doing and if there's room for improvement. So measures and the reporting, again, provide that feedback loop, helping inform the research, which then improves the clinical practice guidelines, et cetera. And then you see in the center, again, the goal is to improve the health and outcomes for all of our population, and in this discussion today, specifically those with hepatitis. Next slide, please. So much like quality improvement cycles, we also have a cycle of the measures themselves, the life cycle of a measure. So we start actually in the center, and then we're always feeding into this conceptualization of a measure, right? So this could be based on, we have identified a clinical or public health priority, we want to measure it, or there's a clinical guidelines if we want to see how well we're complying. So we come together with this conceptualization of a measure. And once the concept is solidified, measure stewards and measure developers work together to specify the measure. Here's where we have our numerator, denominator, exclusions, and risk-adjusted variables if necessary. Once we get through that specification, we go on to testing, and this is very important for feasibility. Is the data available? Is it available in a timely fashion? Are there any needs to go back and tweak those specifications? Maybe the data is not there, and so we can't actually capture everything we had hoped to. After that, we move on to implementation. So during implementation, this is where measures are selected for use. And if a measure is adopted by the government, it is proposed in rulemaking and finalized for use. So the cycle continues with evaluation, maintenance, and updating of the measures. And throughout this cycle, we see measures mature as the evidence and best practice evolve. And again, an example of this would be the hepatitis screening measure, which has then matured into the hepatitis screening and treatment initiation measure, right? So we're going beyond just that screening. We're saying it's positive. We now need to initiate care. Next slide, please. So today we focus on implementation. Specifically, we are here to collaborate around an adult viral hepatitis quality measure that could be implemented at the state level. So next slide, please. We have a poll, and we're hoping we can pause for a moment for your input. So seeing where folks are in terms of their familiarity with viral hepatitis quality measures. And really, really appreciate your input on the polls. This really provides the federal government with key information. All right, looks like things are slowing down a little bit. Justin, if you want to show those results. We have more than 50% of us are just a little or not familiar with hepatitis quality measures at all. So that's really interesting and, again, really valuable information. We've got 10% very familiar, 27% with some familiarity, 40% with just a little, and 24% with no. So again, we will keep that in mind as we go through our discussion today. All right, next slide, please. So if you're not familiar with quality measures, this slide might, be a little bit much. There are many quality measures that was noted earlier, but we want to highlight some of the examples that you might see. So maybe you think you're not aware of them, but here they are. So provider organizations, they use measures to identify internal opportunities to improve care and understand clinical performance. An example would be a provider dashboard with key performance indicators. These might also be used to inform clinician compensation. On the payer side, we have both commercial and government players using measures, and they use that to conduct public reporting and to understand performance. On the commercial side, there's an example with HEDIS measures. I do want to note that HEDIS right now is currently working to include a hepatitis measure, but they do not have one as of this moment. On the public side, the government also looks sometimes specifically to current programs. So in this case, an example would be the HRSA Ryan White program and the Medicare's MIPS program. So looking at a subpopulation within covered lives in the federal government and having some specific measures for them. Next slide, please. So where are we today with the hepatitis measures in government programs? So starting with HRSA, 13 of the 14 measures in the HRSA Ryan White HIV care measures are related to viral hepatitis. For Medicare, the MIPS program uses this in both traditional MIPS program and in two MIPS value-based pathways. We heard about these earlier, promoting wellness and prevention and treatment of infectious disease disorders, including hepatitis C and HIV. And then on to Medicaid, which is, again, you're from the states areas. There are no viral hepatitis quality measures in the Medicaid adult core set. Probably why you don't have familiarity with them. So this gap, as we noted, is really key to our discussion today, and it underscores, it's underscored by the fact that we know that Medicaid covers the substantial portion of people with hepatitis B and C. So we're going to go to the next slide and talk a little bit about those adult core set. So they're actually called the Adult Healthcare Quality Measures for Medicaid. And this is what we hope to focus on today. So the Health and Human Services identifies and publishes a core set of quality measures for Medicaid enrollees annually. The core set is covered for all states, Washington, D.C., Puerto Rico, Virgin Islands, and Guam. And also the core set includes both physical and behavioral health measures. So as we seek to identify a viral hepatitis measure that has broad support, we want to look at what could be included at the state level, included in this adult core set and then used at the state level. All right. Next slide, please. So there are a handful of states, if you want to use the automation, that are currently at the forefront of the viral hepatitis quality measure. But our goal would be to go from those small amount of states to covering and having all states working to collect data on viral hepatitis. So throughout the afternoon, we really encourage you to weigh in both the chat and the Q&A, as well as the polls, sharing your quality measurement experience with hepatitis measures. Especially those that perhaps did not come across our radar when we performed an environmental scan. So we have another poll coming up. This one, we're looking at if your state is using hepatitis B, and then the second poll that will follow on its heels, looking for experience with the hepatitis C quality measure. Again, appreciate all of your input. If you have a measure and you want to share information about it, you can also place links or in a description of the measure in the chat. All right. So it looks like things are slowing down for the hepatitis B poll. And we have about 66% of you are unsure of the status of whether or not your state or territory is using a hepatitis B measure. We have 23% noting that they have no current plan to implement a measure. 5% is planning on implementing, and 5% currently has a measure. Let's go on to hepatitis C. All right, so for hepatitis C, we have 50% unsure if there are any plans or using it. 20% has implemented, 16% is planning on implementing, and 14% has no current plans to implement. Again, thank you. This information is really valuable to us. All right, let's take a look at some of the types of healthcare quality measures there are. There are many. We are not focusing on all of them today. There are composite measures and resource use measures, efficiency measures, patient-reported measures, et cetera. We're going to focus on process and outcome measures today. So process measures focus on the steps that are used to provide care. So an example would be a hepatitis screening and the treatment initiation measures. Outcome measures focus on the results of care. How did we do? How did that patient do based on various protocols put in place? An example would be the SVR hepatitis C measure. Next slide, please. So regardless of what type of measure we go with, it's really important to understand the data sources. They are key and play a huge role in what quality measures you'll be able to pursue. So we know at the state level that use of administrative data is really appealing because it's available in claims and encounter data. It is also dated, and as Deidre had mentioned, there is a lot more information digitally available through EHRs, health information exchanges, et cetera, that are readily available and allows us to get closer to real-time measurement and response. So we are going to take a poll to get a sense of the types of data sources that are available in your state and territory that you're aware of. In this case, we want you to check all of the data sources that apply to you. And if we have left off a data source, please put that in the chat. Thank you. All right, folks are still responding, but things are slowing down a little bit. I'm going to just share what I'm seeing on my side, which is, it looks like the highest level we have is 79% of lab, which is lab data, which is awesome because you can do some very interesting measures with that. We have 60% with claims data, EHR data 50%, registries 40%, health information exchange 28%, patient recorded data 21%, and other. All right. So again, thank you for that feedback. Moving on to the next slide, we want to highlight a couple of the key measures that are currently in use. The one-time screening for hepatitis C, the HCV for all patients is one measure, and this is an example of a process measure. and we will be providing links to this measure and its specifications in the chat. Next slide, please. All right, an additional measure is the one-time screening for hepatitis C virus and treatment initiation. Again, this is an example of a process measure, and we would like to also put the measure and the specifications in the chat. Lastly, we have an example of an outcome measure. So the hepatitis SCV and SVR testing measure is an example of an outcome measure. And again, we'll put the links to this measure and information in the chat. And last slide, please. This slide provides an overview of all of the various measures that our panelists will be talking about today during our meeting. We know that you may need to step away. This is a long meeting. It's going for 4 hours, but if you need to do that, we really request you do your best to get back at 3 o'clock Eastern when we're asking for your input on the type of measure that we might all be able to collaborate around. So I want to thank everybody for your comments and for your poll participation. And we're going to move on to our first panelist discussion. So next slide, I'd like to turn this over to Dr. Ramers and Dr. Wang, who will provide a spotlight on treating and living with hepatitis. Thank you.
Great, thank you so much, Edna, and thanks to the organizers for allowing us to be here. My name is Christian Ramers. I'm an infectious disease doctor and addiction medicine specialist, and I work in a large federally qualified health center in San Diego. We have about 23 clinics and take care of 200,000 people or so. And I've also been involved in some Hep C elimination efforts, both in the county and globally with the Clinton Health Access Initiative. And it just gives me an interesting perspective to see how countries with a lot less resources are doing a lot better than us in a lot of ways. Also very nice to see a lot of colleagues and friends introduce themselves in the chats. A lot of us have been at this for a long, long time. And it's nice to see that we're making progress. Next slide, please. Can we advance the slide? There we go. Okay. I think I'll let Sue introduce herself as well when she starts talking. We're going to do a tag team here. Next slide, please. Okay, here's what we're going to talk about. I'm going to give you my impression of what I think a good public health idea does through the arc of its lifespan, and really suggest to you that we are right now in a knowledge implementation gap phase. We know what to do. We've known this for a long time. This poster behind me, I have had in my office for 10 years. It was produced in 2011. We've known that we should be screening for a long time, and that's the CDC recommendation phase. And here we are almost 15 years later, and really we haven't arrived yet. Sue is going to then talk about what it looks like to scale up hepatitis screening as a system, because all of us operate in health systems, and whether or not Medicaid or the states are sort of aligned with those quality measures, we have things that we've been trying to do at the system level. I will go into a little bit about what it looks like from the clinical or from the clinician level, and then we'll finish up with some pros and cons, and then some ideas that you've already seen about hepatitis quality related measures. Next slide, please. So this is my opinion about what I think happens when we have a good idea in public health. So we have a concept, we have literature, we have morbidity and mortality, we have a good screening test, and we have good treatment that we as clinicians on an individual basis can actually tell that will make a difference. CDC kind of waits until there's substantial literature to support this and looks at benefits and risks, including some cost-benefit analysis, and then puts out a recommendation. This lifespan, by the way, tends to take about 10 to 15 years in my experience, and you can look at HIV measures and hepatitis B and hepatitis C and sort of judge where we are with each of these. USPSTF tends to come in next, and of course insurance companies and payers have an eye towards those guidelines because they talk about cost effectiveness more than anything else. And of course our payers are more interested in cost than really taking good care of our patients. And then it seems like we move into the quality metrics, and it's very exciting to feel like we are almost there, because quality metrics really have that implementation sort of teeth to it, and then you can finally make real impact on patients' lives. We are incredibly busy as clinicians, and we'll show you some screens that are just eye-popping in terms of how complex they are that we are looking at in our EHR on a daily basis. However, it is those quality metrics that our administrators really pay attention to, especially when there is a carrot or a stick attached to it. Next slide, please. All right, over to you, Sue.
Great, thanks, Christian. So I'm really glad to be here. My name is Sue Wong. I am an internist and I serve as medical director for viral hepatitis programs and the Center for Asian Health at Cooperman-Barnabas Medical Center, which is part of the RWJ Barnabas Health System in New Jersey. And I see a couple of New Jersey people here, woohoo. I'm also living with hepatitis B, and I was president of the World Hepatitis Alliance, which is an NGO that really advocates on behalf of people living with viral hepatitis. So we really believe, those of us who've been doing this clinical work and also advocacy work, that quality metrics could really help the US achieve hepatitis elimination by 2030. For those of us who have been straddled working on policy, advocacy, and frontline clinical work, we believe that quality metrics could really help us achieve those targets for elimination. And this is a goal that WHO put forth in 2016 to achieve by 2030, because we do have the tools to do so. And if we can achieve elimination, we're talking about giving the next generation a completely HEP-free future, and we won't be having this conversation, in 15 years. However, our biggest gap right now is in diagnosis. We need to find the missing millions. Globally, only 10% of people with Hep B and only 20% of people with Hep C have actually been diagnosed. This is also an issue in the US, where up to 2 out of 3 people with hepatitis are not aware. And unfortunately, liver cancer rates continue to be on the rise. And the unfortunate outcome is that people don't get in care when they're not diagnosed. They aren't started on treatment, and viral hepatitis leads to cirrhosis and liver cancer. And I've seen too many people who are diagnosed with Hep B or Hep C only after presenting with liver cancer. And they will ask me, how come with all the doctors I've seen, nobody ever tested me for hepatitis? So diagnosis is really that first step to the cascade, and it's imperative for us to really scale up screening so we can get people into care and treatment, and to actually make a difference in decreasing deaths from hepatitis, and to also decrease morbidity from other bad outcomes and improve people's lives who are living with hepatitis B and C. And if you don't care about saving lives or are a cynic, there are plenty of cost-benefit analysis showing that early testing really does save the system money. So I will say that metrics actually, if somebody can click for me, just the next block of text. Metrics actually help promote person-centered care and not just disease-centered care. Right now, so many people with hepatitis are falling through the cracks and not being tested. And we need to deliver person, not disease-centered care, where we are currently really operating in silos, where providers only care about the one issue somebody comes in for. And we need to start thinking about the whole person. We need an integrated approach where hepatitis comes out as specialist care, but really is a part of frontline care. And when we do make it mainstream, we also remove the stigma that often comes from risk-based screening, where we only test if people fall into certain groups, which really perpetuates stereotypes that are not true. Many people with hepatitis are also part of vulnerable populations, often unreached, and don't have good access to healthcare. So metrics can make sure that they're getting important services. So we really believe that ensuring metrics would help ensure that people with hepatitis are not forgotten. And and hepatitis has just been really really has not gotten the attention that it deserves for the number of people in the world who have it. And as we all know, health systems have many, many competing priorities, and metrics can ensure that important services rise to the top. We see this has been very successfully done with breast and colon cancer screening and chronic disease care, like with the plethora of diabetic metrics we clinicians see. And as a clinician, I see constant reminders about diabetic control of my patients, and also colonoscopies that show up in our metrics. So these things do make a difference. Next. So I want to share an example of a systems approach to hepatitis screening. And we really need to focus on how we can scale up testing if we're going to achieve population level goals and reach elimination. So at our hospital, Cooperman-Barnabas, we've implemented an EMR-based algorithm for Hep B, Hep C, and now HIV testing. We started in Cerner just with Hep B and Hep C, and we've now added HIV. And we've also recently switched over to Epic. We're one of many hospitals in the US who have these focus programs that are doing automated screening. And you can see on the right, this is our eligibility algorithm for Hep B and Hep C that we've programmed in. So basically, if a patient is an adult, they're having blood work done, there's no previous diagnosis of Hep B or Hep C, and we don't see any previous testing, then a Hep B or Hep C test is suggested. We've learned that by automating eligibility, this is way more efficient and effective than relying on individual provider training because the EMR can provide that decision support. So currently, because of logistics and priorities, our Hep B and HIV screening are not yet universal, and it's not yet in our outpatient settings, but we believe that if we can get some quality metrics around this, this would actually help elevate and prioritize so we can make these things, these algorithms happen on a universal level. Next. So here's some screenshots. This is what a clinician sees in Epic when a patient is deemed eligible for Hep C testing. They get a best practice advisory or BPA pop-up, which says that the patient has met criteria for Hep C testing following CDC recommendation and then lists the reasons. Next. So what's the process? Because everybody's always worried about, is this going to disrupt our workflow? And we've really tried to make it as seamless as possible. So this is how the pop-up looks in an example patient. So while a clinician is ordering labs, the BPA fires if eligibility criteria are met in the background, and they see this pop up on the left, kind of overlying the screen. All the provider has to do is just hit accept, and the hepatitis lab tests are added to the orders, and the provider signs off on all of their orders together. And there is also an opt-out, so a provider can choose not to order, do not order, if a patient declines, or they're in hospice, or there's some other reason. Next. So this graph shows the impact we've seen in our Hep B, Hep C, and HIV screening scale up, and why we think these kind of system-wide efforts are really important strategies for the goals of ending the epidemics. So the red line is Hep C, the blue line is Hep B, and the yellow is HIV. In the yellow section on the very left, this is before we had algorithms. We were practically doing no Hep B or Hep C testing. And the uptick in the green section is when we started doing baby boomer Hep C screening in 2018 and Hep B testing by country of birth. Now, the really big uptick, what you see here in the purple, is when we went to universal Hep C testing, and we're doing about 2,000 to 2,500 tests a month now. And the trickle down you see is because we don't retest people if they've been tested, and obviously people come back to the hospital for their services. So we don't recheck them. And so overall, we've tested more than 47,000 people for Hep B, finding 415 people infected, which is double the national prevalence. Hep C, we've screened over 107,000 and found 426 infected and linked them to care, the number being successfully cured for Hep C. And I have to say, we've just heard so much gratitude from patients that they were so glad that they were tested in the ED, even though that's not what they came in for, and they are just so happy that they are cured now. For many, this has actually changed their lives. Many have gotten motivated to get care for their other chronic conditions. So I believe that hepatitis screening is often a gateway for better overall health for a lot of people. Next. Which leads me to this slide, which is our dream algorithm of universal HIV, Hep B, and Hep C screening. We believe it is really time to integrate bloodborne virus screening, since we now have CDC recommendations, as Nathan talked about, for universal testing of all three. We think that quality metrics could be a game changer to make this a reality. And we hope that all of you here can be a really part of supporting that effort. And I will now turn it back to Dr. Ramers to talk more about what metrics look like in the day-to-day life of providers.
Thank you, Sue. I realize we are already over time, so I will try to wrap things up quickly. I just want to show you what things look like to me as a clinician. This slide gives me heartburn. I don't know about you, but there's just too much here. But at the same time, there's nothing here about hepatitis. And as somebody that's been working in this area, I feel like we are not paying attention to the right things. We have a quality metric on sending an LDL on someone on an antipsychotic, which is a tiny little narrow carved out thing. Why is that one of my quality measures when I don't think anywhere close to 50,000 people die of having high LDL on an antipsychotic, whereas hepatitis B and hepatitis C are killing our patients regularly. I like to show this also to show you that this is one of about 50 different panels that I get that are just quality reports back to me that we have by clinic, by provider, by area. And again, hepatitis is really not on the map, and I think we all agree it really should be. Next slide, please. So when you're in my actual EHR, this is what things look like. The right side is my note. The left side is all these other things that I have to choose from. We actually have our own proprietary EHR that we've developed. And it's not in your face popping up because pop-up fatigue is real, but there is this little aid tab that I've circled in red here that at the end of a visit, I can click on that very quickly. And if we go to the next slide, it shows me the things that are relevant to the particular patient in front of me that I've not done. You can see COVID vaccination here, colon cancer screening, which is kind of ironic because this patient already had colon cancer screening, as I say in my note, but the quality metric was not captured there. And then there's a whole bunch of things that are hidden here to not bother me and not distract me when I have 10 minutes to talk to this patient about their issues. If we go to the next slide, I click on show all if I want to, and then next slide, please. This is all the things that I've already done. And next slide, we can animate to the things that are relevant here. So this is a patient actually with hepatitis B. So the Hep B decision aid for me has already been satisfied. I've already vaccinated her against hepatitis A. And today, I should give her pneumococcal vaccination there. So these things actually really do work. And we can sort of take them and use them within our EHRs to make real impact on patients. Next slide, please. So here's some opinions about what I think are the pros and cons of quality metrics. We have really all committed to these as a system, as a state, as a jurisdiction, as a health center, and as a capitalistic American healthcare system, for better or worse. These are agreed upon objective ways to measure whether certain things are actually occurring at the end of a visit and are being achieved at a population scale. We've shown you in the individual patient case and as well as in the systems case how these things can operate. Providers, again, for better or worse, are basically trained to care about them. And I didn't mention this, but that large dashboard figure that I showed you actually translates into incentive bonuses. So you can get up to $10,000 per year as a clinician if you hit all of your quality measures, and that absolutely drives behavior. And finally, if the right measures are chosen, you can actually impact care. And what I mean by that is incorporating something like an SVR12 is actually going to result in more cures. And that to me is a great step towards elimination. Now, this is not all rainbows and unicorns. Clinicians will push back hard against these being the primary thing or the only thing that you care about, because quality measures do not capture the full spectrum of what medicine actually is. It does not capture the bedside manner, what the patient experience is like, all the counseling we do, all the education. Many clinicians feel like it's an intrusion upon their autonomy. And when you have 10 minutes to run a visit and 5 minutes are spent clicking boxes, that's really not a good feeling and contributes a lot to burnout. And it does minimize the clinical evaluation of complex people in complex environments with complex conditions. And it really rudimentalizes them into sort of these simple measures. Finally, these are not often responsive to patient priorities. And when you have patient satisfaction surveys at the same times, if we focus only on quality measures, then we get bad patient satisfaction measures. So it's a complicated thing to be as a clinician, often feeling like you're being pulled in many different directions. And then the fear is that this reduces clinical evaluation to checkbox medicine. And then you don't really need a doctor. You just need some kind of AI chatbot to do your healthcare for you. And I don't think any of us want to live in that type of world. Final slide, please. So I know we're going to talk the rest of the meeting about all these different measures. Here's how I see things. If we finish this meeting and don't have this basic package, we will have completely failed, and we will have spent 15 years really not reaching towards where we need to be. We need to have one-time HPV and HCV screening. We need to have reflex RNA so we don't lose those people from the antibody to the RNA. And then for God's sake, we need something that's an actual outcome that will get people treated and cured. And the lowest hanging fruit, in my opinion, is the HCV SVR12. I work in HIV as well, and then of course see all these other primary care things. And there's other measures, whether they be Ryan White quality measures, performance measures, the whole HIV-Qual program that we've applied all through the world in our PEPFAR programs that are quite sophisticated. And they look at pneumococcal vaccination and PCP prophylaxis and all these things that we know contribute to high quality care. So I've listed a whole bunch of other things that we could include as a high package for high functioning health systems if they really wanted to take this seriously. So I think we're a little bit over time, so I'm going to stop there and turn it over back to our organizers. Thank you so much.
Thank you. Wonderful, wonderful discussion, great energy, and provided again some really rich context for our discussions this afternoon. We are going to go to a break. We are going to make it a 5-minute break, catch up a little bit of that time. So we'll see everybody back at 1:05.
All right, everyone, welcome back from a short break. We've had a terrific discussion so far, and we are about to enter our first panel conversation. My name is Nicole Kemper, and I'm the Vice President at Clinovation's Government and Health. Along with my colleague Edna Boone, I've had the honor to work with the OIDP team to prepare our conversation today. So let's begin it. As Jessica summarized at the beginning of the meeting, our objective here is to work with you, state leaders, all of the stakeholders on the line, to get feedback on the feasibility of testing and implementing a viral hepatitis quality measure at the state level. And to help you inform your feedback, we have assembled a terrific panel of state representatives. What we will do in our first panel is hear from their experience what it was like to develop, test, and implement a viral hepatitis quality measure in their state. And we want you, our attendees, to be listening to them and reflecting on their experience and how it applies to you in your state, so that you can inform your vote that will be held at 3 o'clock, so that we give that feedback to OIDP. What I would like to do is next introduce our panelists. We have Medicaid and public health representatives from Louisiana, Michigan, New York, Pennsylvania, and Washington. Let's flip to the next slide and start introducing them. All right, Louisiana panelists, I'll let you introduce yourself.
Hi, everyone. My name's Lisa. I am the Hepatitis Surveillance Supervisor at the Louisiana Department of Health, Office of Public Health, STD HIV Hepatitis Program.
Hello, everyone. I am Debbie Wendell. I'm the Data Management and Analysis Unit Manager. I'm also with the Louisiana Office of Public Health in the STI HIV Hepatitis Program.
Hi, everyone. I'm Herbert Twase with the Louisiana Department of Health Medicaid Program.
Welcome to our panelists. And please, can you take a moment just to describe the measure that you have in your state?
Sorry, I was trying to unmute myself. Yes, so we have one measure currently, and it's the hepatitis C virus screening measure. And this measure was created to improve the HCV screening in our Louisiana Medicaid population. And this measure is calculated annually. So for the numerator, we have Medicaid members in the eligible population who have ever received at least one screening for hepatitis C. And then denominator is Medicaid members between the ages of 18 years as of January 1st of the measurement year and 79 years as of December 31st of the measurement year. This excludes members where there is evidence of Medicare or third-party insurance during the continuous enrollment period. And our data sources come from Medicaid claims data, the Office of Public Health, STD HIV Hepatitis Program surveillance data. And this was first calculated in 2021, and it's now an annual measure.
Thank you for that quick overview. We will be returning in a few moments to discuss this more in depth and start asking you some questions about it. But in the meanwhile, I would like to invite our panelists from Michigan to turn on their cameras and start to introduce themselves and their measures. Welcome.
Hi there, I'm Matt Seeger, Michigan Medicaid Managed Care Quality Section Manager.
Hi, everybody. My name is Jeff Brusso, and I'm the manager of the Viral Hepatitis Unit at MDHHS.
Welcome. And on the next slide, will you also take a moment to describe the measures in your state?
Absolutely, I'll take this one. So we have 3 that we're using right now. I think later in the panel we'll talk about where they came from more, but they're really built off CDC recommendations. So the first of the 3 you see here, lifetime hepatitis C screening, is very similar to the one that our friends from Louisiana just shared. So it's the same, I would say, overall measurement concept. It's an adult lifetime hepatitis screening measure. You can see the description there. The second is similar, but really zeroing in on hepatitis C screening during pregnancy. You all will remember from the beginning of today's discussion where it was recommended that everybody get a hepatitis C screening during pregnancy. So that's what the second measure is getting at. And then our third hepatitis measure, which we call hepatitis C treatment, is really looking at people who received the appropriate medication for hepatitis.
And thank you for going over those. Yes, indeed. We are going to come back to all of them. Thank you very much. I would like to welcome our panelists from New York to turn on their cameras, introduce themselves and their measures.
Hi, everyone. Colleen Flanagan, the Director of the Bureau of Hepatitis Healthcare and Epidemiology at the New York State Department of Health AIDS Institute.
Hi, this is Paloma Luisi. I am the Director of the Bureau of Quality Measurement and Evaluation. I sit in the Office of Health Services, Quality and Analytics at the New York State Department of Health.
Welcome. And on the next slide, will you describe the measure in your state?
Sure, thank you so much. So our planned measure is hepatitis C screening among pregnant people. We will use the New York State Medicaid Data Warehouse. Beginning in May of this year, New York State will require all pregnant people to be screened for hepatitis C during each pregnancy, aligns us with the CDC recommendation. So the description is the percentage of Medicaid members who are pregnant and receive a hepatitis C screening test. The numerator, Medicaid members who are pregnant and receive the test, and then the denominator is Medicaid members enrolled in Medicaid for 2 or more months of pregnancy and had at least one pregnancy related to service 14 or more days before delivery.
Thank you, Colleen, and more on your proposed measure in a moment. Let's take a moment next to introduce our panelists from Pennsylvania. Welcome.
Hi, good afternoon. This is Dave Kelly. I'm the Chief Medical Officer for Pennsylvania Department of Human Services, or Office of Medical Assistance Program, which is Pennsylvania Medicaid.
Hi, I'm Lauren Orkis. I'm the Viral Hepatitis Epi Supervisor at the Pennsylvania Department of Health.
And welcome. Please take a moment to describe the measures in your state for the audience.
So within Pennsylvania Medicaid, we have looked at both hepatitis C screening, but then also look at those that get screened that actually have a diagnosis, and then we move towards what I call the treatment cascade. So we're looking at this in a series. We actually do this, we do the screening and testing also for a subpopulation for our pregnant individuals, and we do a screening measure for a subpopulation of individuals that are in our opioid use disorder centers of excellence.
Thanks. And what can you tell us about the data sources for those measures?
So our data sources that we use actually come from our Medicaid data warehouse, our enterprise data warehouse that houses claims and encounters that we get from all of our MCOs and fee-for-service programs.
Great, thank you. And we look forward to talking more about that as our panel gets underway. Thank you, Lauren and David. And last but not least, let's introduce our panelists from Washington.
Hi, I'm Emily Curio. I'm a program manager at the Washington State Department of Health in the Office of Infectious Disease. I manage our hepatitis C prevention portfolio, our drug user health portfolio, and our integrated infectious disease testing portfolio, which includes HIV, viral hepatitis, and STI testing. Thanks for having me.
Hi, I'm Laura Pennington. I'm the Quality Measurement and Improvement Manager here at the Healthcare Authority, which is our state Medicaid agency. I oversee our state common measure set, as well as the work of our Performance Measures Coordinating Committee and our internal Quality Measurement, Monitoring, and Improvement Program. Glad to be here. Thanks.
Well, welcome to you all. At this time, I'd like to introduce all of our panelists to come back to the stage. And as you're doing that, a note to our audience gathered with us today. We'll spend about the first hour of our conversation with our panelists just talking to them about their experience. I have a number of prepared questions that are intended to draw out their perspectives and expertise for you. As you're listening to them, please feel free to put questions that you have and would like to be answered during our question and answer session in the chat or in the Q&A box. We'd like them in the Q&A box preferably because that's where we'll be able to get some discussion going around a similar thread, but we'll be looking at the chat box too. So expect about an hour of direct conversation with our panelists, and then we will do 20 minutes of Q&A at the end of panel 1. After that, we'll take another break and then shift into our next panel. So we'll go ahead and turn the slides off now, and I'll welcome all of our panelists to have their cameras on. Great, welcome back everyone. So you've just spent a moment talking about the measures that are implemented in your state, in the works of being implemented, or have been recommended. I'd like to ask you all to tell us a little bit about what factors drove your decisions to focus on the measures in your state. Let's start with Louisiana.
Okay, so for us, we decided to measure or focus on hepatitis C as opposed to hepatitis B because, as you all know, Louisiana has the hepatitis C elimination plan, and that was like one of the driving factors for that. And then Herbert, do you have anything else you wanted to add?
Yeah, I think, as you know, Louisiana ranks among the highest in liver cancers. So based on the state affairs in Louisiana, by then in 2019, Dr. Rebecca Gee launched the project eliminating hepatitis C from the state. So we partnered with different stakeholders, including IBM. And then also the other point as well is also about LDH leadership priorities and goals. We currently have a new governor. So again, that may determine where we go as the Department of Health in terms of setting the next priorities. Yeah.
Thank you for that overview. Let's go next to Michigan. Tell us a little bit about the factors that drove your decision to have not just 1, but 3 measures in your state.
Yeah, I can kick things off. I think, at least in Michigan's case, we used the CDC testing recommendations that were covered earlier in this presentation, just kind of being able to measure, adults who were screened for hepatitis C, pregnant persons who were screened during each pregnancy, and then also one thing that we've been focusing on in Michigan is really accurately describing that hepatitis C clearance cascade. And so being able to measure each step of that clearance cascade. And so our last measure of initiation of treatment, just seeing what that looks like for our Medicaid beneficiaries.
Mm-hmm.
Thanks, Jeff. And I'll say from a Medicaid perspective, when public health approached us with these measurement concepts, we were really excited to oblige because we in Medicaid feel that our public health colleagues are the experts on where the need is. So that's kind of where the partnership started.
Mm-hmm. Okay, good. So we've heard a little bit from Louisiana and Michigan that they were looking at the data in their states, looking at where measures needed to be. Great to know. Let's keep going through our panelists. Representatives from New York, it would be great to hear a little bit about the measure that is currently in development in your state. Tell us a little bit about the factors that drove you toward that measure.
Yeah, sure. Thanks, Nicole. So, as I mentioned when I was describing the particular planned measure, we do have a policy change that will take effect in May. Like I said, that all physicians attending to pregnant people will have to order a hepatitis C screening test. And so that drove our reasoning, as well as our elimination plan, as well as our surveillance data, where we do see over 60% of our female cases among persons of childbearing age. And then also we did a blinded seroprevalence study with our state lab looking at samples that come through our newborn screening and did some extrapolation of the data from that to what we would expect to see in terms of mother-to-child transmission. And we saw that we're probably missing a number of not only pregnant people, but also babies who were exposed to hepatitis C. And we know there's national data that supports the need to do more around getting those exposed babies screened. So while the measure is not aimed at the exposed infants, if you follow the parent-infant pair, we will get to that.
Oh, good. So you brought out a factor that we hadn't heard before, and that was the policy change that will be implemented in New York State around screening. So note to all of those listening that was a factor we hadn't heard about before, and we can certainly come back to hearing a little bit more about that if there's some interest. David and Lauren in Pennsylvania, tell us a little bit about how you pursued the measures in your state and what was driving you.
Well, I'll briefly start and then I'll turn it over to Lauren, but I think a lot of this was driven by Lauren and a multi-stakeholder group in really discussing what was the type of Medicaid-related data that they needed to really drive our hepatitis elimination plan statewide. So it really was a multi-agency, multi-stakeholder process that, and we worked together to really define some of the data elements that we wanted to look at from a population standpoint, from a Medicaid standpoint. Lauren?
Yeah, just to add there, I think that our Medicaid partners are absolutely critical in our elimination planning efforts statewide. So we made the partnerships strong between DHS and DOH in Pennsylvania from the get-go as we got our elimination plan underway, and they're critical partners really in the implementation of our plan as well. So really happy with the collaboration. Thanks so much.
Thank you both. And when we turn to Washington for this, for a little bit of background on their measure, I'd like to invite the slide on their measure to be reposted, because I'd like you, when you speak about the measure for our Washington State panelists, I'd love you to talk a little bit about the BRIE Collaborative and the role that it has. David provided a really nice segue by mentioning a multi-stakeholder group. So let's get the slide of your measure back up and have you tell us a little bit about it.
Sure, I'll describe the BRIE Collaborative very briefly. Washington State has a group that's legislatively mandated called the BRIE Collaborative that makes recommendations about quality improvement for healthcare delivery, and their recommendations are specific to the Medicaid program. But as I understand it, often their recommendations are embraced by health systems and payers more broadly in the state beyond Medicaid. So they've looked at things like access to medications for opioid use disorder, LGBTQ plus healthcare delivery, management of chronic diseases, a wide variety of health topics. And so they pulled together a group around hepatitis C because we do have a hepatitis C elimination initiative, Hep C Free Washington, that's a partnership between Department of Health, Healthcare Authority, and community partners, wide variety of partners around the state. So they embraced a hepatitis C group to make recommendations, and that group submitted several recommendations, but one set of recommendations was specific around these quality measures. And the group felt really strongly that we needed both a screening recommendation and a treatment recommendation. In Washington, we do think we've done, from the data we have, we think we've done a pretty good job of screening, and where we are mostly falling short is around access to treatment. We completely, I think, line up with other states around the screening recommendation, very similar in language. And then we really wanted to look at treatment access and recognizing that it's really difficult to get outcomes data through claims data, but we can get access to people with a positive RNA test who've received a prescription for DAAs. And because most people do fill their prescription, and if they take their DAAs, they do achieve cure, the group felt like that was a good enough proxy for that outcome. So that's kind of how we got to these two recommended measures.
Great. Great, thank you for that overview. And I'm glad that we got to go back to your measure. What I'd like to do now is with all of our panelists together now, now that the group in our meeting today has had a chance to hear about your measures, what we've heard is that there's a real range of measures. We have some that are what would be termed process measures that focus on screening and treatment. We also have some that veer into outcomes with SVR measured. And what I'd like to do now is to get into a little bit of discussion about what your experience has been for those that are measuring outcomes and the experience for those measuring a process measure. And while we're having a conversation about how did you select your measure, really help us understand if that differentiation between an outcomes measure and a process measure informed your drive to go with that measure or measures. Can I invite our panelists from Louisiana to speak first?
I think I'll go. This is Herbert. I think for us in Louisiana, we had a lot of stakeholder engagement. In 2019, our Medicaid chief Medicaid officer traveled around the state from Shreveport to New Orleans seeking feedback. We had a lot of public forums, so we received a lot of feedback from providers, and their push was towards hepatitis C screening. And we took back that feedback, and then also a couple of things were going on. Like I said, in 2019, Dr. Rebecca Gee also started the elimination of hepatitis C around the state. And then also we collaborated with the correctional department because most of those offenders, as they go out, it was difficult, as they go out in the public. So we wanted to track them before they went out, before they were released. So there was a lot of collaboration. And then also we collaborated with also our sister agencies, talking about Office of Public Health, Office of Behavioral Health, Medicaid, within the Louisiana Department of Health. And then also there was also some legislative push, I think must be House Bill 704, something like that. It's on hepatitis C and HIV/AIDS as well. So there was some movement there as well. So I'll let Lisa and Debbie add on if, yeah.
I think Herbert covered it well. I don't have anything extra to add.
So would you say in general that it was the voice of all the stakeholders that you spoke to that really made you want to focus on a measure that was going to be about screening, a process measure on screening? That message came from the stakeholders that you were speaking with and connecting with?
Yes, precisely. And the other bit of the stakeholders I wanted to add on, we have Medicaid advisory councils. Within those Medicaid advisory councils, we have different specialty groups, OBMFM, pediatrics, dental, that sit, behavioral health, that sit on those advisory councils. So there was also feedback from that direction for us to focus on hepatitis C screening, especially the adult subcommittee that sits on a lot of primary care providers and specialists. So there was also some movement there as well. The other thing I wanted to add on, we also collaborate with the University of Louisiana at Monroe. So they are the ones that that Medicaid we collaborate with in mining the data. So it's they have a research group up there, and as you know, it's a state-specific measure, so they help us with that as well. So yeah,
that's great. That's great. Thank you for talking through that. Let's hear a little bit from our panelists from Michigan. The question that we're after here is, what drove you to focus on a process versus an outcome measure? Now you're in the position where you have 3 measures and they span. So what I'd like to do is actually invite you to help us understand if there were factors that drove all 3, or if you knew from the start that you always wanted to have that range of process and outcome measures.
Yeah, no, I think it all began in my predecessors in the viral hepatitis unit got this started, but the hepatitis C Medicaid affinity group was really helpful in kind of breaking down some of those silos between the Medicaid program and the public health side of things in Michigan. So once we had those consistent communications, I think it helped us really have some make some progress when it came to removing barriers to prescribing hepatitis C treatments in Michigan. And so it eventually led to our agreement with AbbVie to through our We Treat Hep C initiative to provide the direct acting antiviral Mavyret at a discount to some of our Medicaid beneficiaries. And so removing some of those fibrosis restrictions, sobriety restrictions, provider restrictions, we eventually got to the point where, hey, what can we do next to kind of get more folks, tested and treated and Medicaid beneficiaries tested and treated for Hep C. And so that kind of spurred the process when it came to looking at what recommendations were in place that could potentially assist with that. And so that's how we eventually went to the CDC recommendations and some of the best practices for screening adults and pregnant persons during each pregnancy. And then kind of again looking at that clearance cascade. We have dedicated funding for hepatitis C DIS in Michigan, and so there's a finite amount of resources that we have to follow up on cases. So we want to make sure that we're using those resources to the best way possible. And so getting negative lab reports, and so we're able to look at the clearance patients that have cleared the virus in Michigan. And so yeah, I guess those are just the main reasons, I guess, why we chose those particular quality measures in Michigan, just from our previous relationship with our Medicaid program. I don't know, Matt, or was there anything else that you wanted to add to that?
Yeah, that was a great explanation, Jeff. So, again, we have 2 screening measures, which are, pretty straightforward process measures of lifetime and a pregnancy. The third measure related to medication adherence and access, I think probably technically still qualifies as a process measure, but gets into outcomes, at least in the sense of was the individual able to access the medication? And then we know there's all sorts of barriers that could be associated with that. Did they have access? Are there regional impacts, or there racial disparity impacts? So I think that one's really interesting in terms of the medication component. It gets a little bit, not into the overall health outcome, but certainly outcome of whether the individual is able to access the medication. And then the other thing, of course, that was great for us in Medicaid was that the measures that the public health team had proposed to us, or the measurement concepts, we were able to do all of those using purely encounter data. So that makes things simple for us.
Right. Great. We've been hearing a lot of great anecdotes about and factors that are driving driving the selection of different measures. Let's go to New York now. You had brought up the change in a screening regulation that will make it a requirement for physicians to screen patients in New York. Tell us, was that the primary driver in your state, or were there other factors that led you to think about that measure?
I mean, I think that was the primary driver of wanting to look at this particular data. We do have a policy change requiring universal screening of all adults, but the way the language in the legislation is written, it says offer. So it's a little bit tricky to try to collect that data or that information just because the person can decline. And we don't know if they declined the test or if they were offered. So whether, the difference between declining and actually whether or not they were offered. As I said before, universal screening among pregnant people is a priority recommendation in our elimination plan. We did do some looking at Medicaid data when CDC came out with their recommendation, pre-post the recommendation to see if we saw an uptick. So, working off of that particular algorithm or building on that particular algorithm will help us with this particular measure. And then the data and the fact that, we have a cure. And so this is a population in terms of microelimination that we can really focus some of our work on. And so we feel as though having this quality measure will give us or actually motivate providers to actually do testing.
Great.
I don't know if my
Thank you for
colleagues,
sharing that.
if Paloma or Nicole have anything to add.
Oh, good. Thank you.
Thank you. Thank you. Well, let's hear from the last two states that we haven't heard from yet. Pennsylvania and Washington, as you think about the factors that drove you to look at your measures, was there anything about their categorization as a process measure or an outcome measure that was a leading factor for you to pursue those measures in your states? I'll invite you both to speak if you'd like before we move on to our next question.
Well, from Pennsylvania's standpoint, I think we really wanted to assess what's happening within our Medicaid population in general. And that's why we wanted to look not just at screening, but who then tested positive, but then who also moved into treatment. So we really wanted to look at that across the broad adult population. And we did it for both Hep B and Hep C, but we also did a focus study on our pregnant individuals as well. And we also did a focus study on individuals in our opioid centers of excellence that are obviously at very high risk for Hep B, Hep C, and HIV. So that drove our strategy. And then those are processes. We contractually require our MCOs to actually track the SVR12s, and actually we provide them an incentive. So that is our outcome measure. Over the years, over 90% of the SVR12s for folks that start treatment, we get an SVR12, and the cure rate for the ones that we get the SVR12s on is very high, 97% or so. So that's what really drove some of our decision making. And again, we used our Medicaid Research Center university partner to really do a multi-year claims run from 2016 to 2022. So we did a multi-year look because we wanted to see, were we making any progress? So that's what drove a lot of our decision making. I would say also we did a policy change where we pretty much for preferred products for Hep C, we eliminated prior authorization.
Thank you, David. Anything that you'd like to add, Emily, Laura? I can add just briefly from Washington. When the Hepatitis C work group was making recommendations to the BRIE collaborative around quality measures, there was a lot of conversation about this process versus outcome question. And as we reflected on what data sources we have access to, there's a real inability to track a really clear outcome measure using the data sources we have available. In Washington, RNA results, positive or negative, have recently become reportable. So prior to that, only positive RNA results were reportable to public health. Now that the negative results are, theoretically, that should be data we could use to track cure, but we know that that reporting is still very spotty. It's a new requirement. And when looking at what are reliable sources of data, claims data seem to be the most reliable. So when thinking about both a screening measure and a treatment measure, the group really made a conscious decision to rely on creating recommendations that would only rely on claims data to be able to measure them. So that was the real thinking there. And the thought being that with folks accessing DAAs, if they're prescribed, most of those people do go on to fill that prescription and achieve SVR12. So it felt like a really fair proxy for an outcome measure, even though the treatment measure that we've recommended, is not an outcome measure precisely.
And I would just add really quick, due to the Hep C Free Washington initiative, this is a topic that was brought to our performance measures coordinating committee for consideration for adding to the common measure set. I mean, several years ago. It's the data that seems to always, stop us from adopting a measure that's really meaningful. There was a lot of conversation at that table too about an outcome measure being more meaningful. So we kind of parking lotted it until we had the right data. We did a similar thing with the HIV viral load suppression measure, which we recently added to the common measure set. So kind of to David's point about the Medicaid, once we add a measure to the common measure set, that is what we use to drive the information that goes into our contracts with our MCOs. So that's kind of where I think we're wanting to head. But yeah, once we can find the right data source, I think that really helps move things along quicker.
These have been fantastic comments, and I can tell it's also sparking conversation in the thread. I think we have a lot of discussion to come back to with the points that you've made around the role that data sources play in having you consider a measure that focuses on outcomes versus a measure that focuses on process. And we've also heard the nuance that when you're looking at a treatment measure that you start to get a sense of that data element, treatment initiation as a proxy, that you can tell that things are going in the right direction with the population you're looking at. So let's come back to that thread. What I'd like to do with the 30 minutes or so before we get to Q&A is to have a conversation next about some of the other processes and experiences that you've had in your states as you have implemented these measures. So let's talk a little bit about the process to develop and test your measure. I'd like you each to tell our audience a little bit about what your process was. Did you start with a template with an existing measure specification, or was it really, as some of you've mentioned, that you were looking at trends and you wanted to more organically develop a quality measure that would help you understand what's happening in your state? Let's start with Louisiana, please.
Yeah, for us in Louisiana, we started with the template that we sent out to the MCOs, our partners from the University of Louisiana Monroe. They help us mine that data, and we send out a template to the MCOs, managed care organizations. We currently have 6 in Louisiana, so we started with that. And then also there was a look back period in the data warehouse before we started the whole process, just to look back on what's in there in terms of the data. So that's how we kind of went around that.
Mm-hmm. So would you characterize that as, yes, please.
Oh, I was just going to say, I just wanted to add that it is a locally developed measure, so we didn't use any templates from any other states. And ours is a little different because we do include surveillance data in our measure, so the data for the numerator aren't just coming from Medicaid claims data. So our measure is very very specific to Louisiana, which I think has its pros and cons. It's probably more complete adding the surveillance data, but then we're not really able to compare our measure to other states that are just using claims data.
There's another really important point that you just raised there, because if one of the aspects of pursuing a measure and to be proposed for the Medicaid adult core set, there would be that level of consistency, and that'll be a benefit that we hope to see in the future. So that was really helpful. Thank you. Michigan, let's hear a little bit from you. Tell us, did you start with an existing template for your measures, an existing measure that you may have seen at the national or another state level, or did you organically create your measures?
Yeah, it was a very organic process. So, as my colleague Jeff already mentioned earlier in the panel, our public health colleagues wanted to take those three key CDC recommendations, the screening recommendation and the Medicaid adherence recommendation, and reimagine those as Medicaid quality measures. And so we felt we could do it just using claims data. And so we put together sort of a query numerator and denominator using the claims data. We felt that the rates that were coming out looked accurate. We ran them against the public health team. Do these numbers feel right? We ran them in front of our Medicaid health plans. It looked good to us. So the whole process came together very, very quickly, honestly, in a matter of weeks. And then we were able to put it in the health plan contracts, alerting them that we're going to be monitoring you on your performance on these measures.
Mm-hmm. Great. New York, I know that your measure is in development. Is there anything that you would want us to know, even though it is a future measure to be implemented, anything you'd want us to know about your process in terms of using something that you knew and recognized versus the other end of the spectrum of kind of looking at what you wanted to know and coming up with a measure?
I mean, I'll just say real quickly, I think it happened more looking at what we knew, what we had. The folks that run the Medicaid data for us in the AIDS Institute are very familiar with, working with the HIV data. So it wasn't something that we used a template from another state, but like I said, we did run the data on Medicaid data on screening in pregnant people when the CDC recommendation came out. So that was when 2020. But I don't know if Nicole or Paloma want to add anything to that.
No, I think that's correct.
I'll just add that, I think we have like a pretty robust measure development, approach here in New York State where, and those wonderful slides at the beginning. And so I think we kind of have a sense of what will work, and we really make sure that we can program it ourselves before we ask anyone else to do it. And we have a series of, checks boxes that a new measure must go through that has led to success in the past. That's all I wanted to add to that.
Oh, good. Well, we're going to be asking you about those in just a moment. Pennsylvania, how about you? Did you start with a template, or did you more organically create your measure?
I think we organically created it with our Medicaid Research Center at the University of Pittsburgh, and then we did get feedback from our Department of Health, from Lauren and other stakeholders about what they wanted. But we started from scratch. I would make the comment, though, if we want to get something onto the core set, that we really need to have something that's consistent across all states and that can then be benchmarked. So I think that's really vitally important, and hopefully we'll get to that discussion later. But we started from scratch, but there's enough specs out there right now that we could probably find a lot of commonality between what states are doing. And I bet there's only some slight nuances to the specs if you looked at them across all of the states that are on this panel.
Thank you. Laura and Emily, I know that you're looking at measures that have been recommended by the collaborative in your state. Are there any comments that you'd like to add related to the discussion that you've heard with the co-panelists here about your thoughts on templates or organically creating your measures?
I think Laura may have some good insight into sort of the importance of national measures to sort of getting things into our common measure set in Washington. But I will just say, I think like other states, the BRIE collaborative work group that looked at hepatitis C created these organically, though obviously, you know, I think they're all very similar because we looked at CDC recommendations. So I think that's a common thread here. But because the national measures we had found were very old and not relevant in the era of DAAs. So we did create, you know, organic recommendations. But I agree, I think there's a lot of similarity across what states are either implementing or working to implement, and it wouldn't be that hard to, I think, find some common ground for a national measure or measures.
Yeah, I agree with that. I think that, you know, our Washington State Common Measure Set is legislatively mandated, and one of the main criteria is that we align with national measurement. And that's where we failed to add a measure prior because the measures were not the right measures for us. So we kind of just kept our eyes on the landscape. And we do occasionally, we try not to, but we do occasionally find ourselves having to create a homegrown measure. It's not something we like to do, but sometimes, you know, national measures that are in use in national programs don't really fit the needs of our state. So we do work closely with the BRIE Collaborative, and they participate in the Performance Measures Coordinating Committee to bring in some of those measure recommendations. An example is a OUD treatment measure. We added 2 from the BRIE Collaborative, and we adopted the HEDIS one. And the HEDIS one we use for accountability purposes, but the other 2 we use for monitoring purposes, because we know that health plans, you know, are not required to report on those measures. So we kind of use a combination. So at the end, whatever works for our population. But I agree.
Well,
we definitely can look at aligning with what's going on across the country as well.
Yeah, great. These have been very insightful questions. You've made it all sound like something that reads from a textbook as if there was a roadmap, but I know that's not what it looks like on the ground. Let's turn to some of the practicalities for how you make this happen. I'd love for the panel to now share some of their experience with what were the tools, what were the resources you needed, and if you could particularly talk about the role of data sharing agreements and the enabling role that they have for quality measurement in your state, that would be terrific. We've been going alphabetically from top to bottom, but let's mix it up a little bit and start from the bottom. So Washington, I'm going to skip you for a moment, but Pennsylvania, tell us a little bit about the practicalities that other states who are listening must leave this meeting knowing.
Well, I think if you want to get to let's say an SVR 12 outcomes measure, I think you really do need to better leverage health information exchange, EHR extraction, or working with our Department of Health colleagues. And here in Pennsylvania, we're still working on that process. And I don't know if Lauren wants to talk about that, but there, you know, our Department of Health does get reportable labs. However, she can elaborate. I don't know, but I don't think the negative results are reportable or mandated to be reportable. But Lauren, maybe you could talk about that.
Yeah, so I've seen that a bit in the chat here as well. So in Pennsylvania, negative HCV RNA results are not mandated to be reported. And we are actually in the process of trying to change our regulations, but this process has taken about 23 years. So we're not holding our breath, unfortunately. So we've got voluntary HCV RNA reporting from most major labs. So we are, like Dr. Kelly said, in the process of figuring out if data sharing is possible for us between the 2 agencies. But, you know, if it is, we are going to have that stipulation that, you know, not all results are available to us on the negative side, but I'd say the vast majority from large labs are. So a good alternative source potentially.
And we already get about 90% of the SVR12s back on folks that go through treatment, and our cure rate's very, very high. So there's still a little bit of that gap in getting those SVR12. So we'd like to fill that gap if we could, but that is, as you heard, is definitely a challenge. And again, there may be other means of getting this through, and we make our MCOs gather this information through EHRs, through health information exchange and other venues. But I really also like the MIPS, that avenue where, again, providers, I think, are given the ability to report that electronically.
Absolutely, and we're going to come back to MCOs before we get to Q&A. So absolutely hold that comment. Let's come back to that so we can get into the role that they play in really making these measures have an impact. But let's hear a little bit from the other states. What would you have our audience know about the real logistics and practicalities? Tell us about data sharing agreements. Tell us about the kind of resources and partnerships that you needed. I'll open the floor to anyone who would like to go next, and call on you if you don't want to speak up.
This is Debbie. I could go next. And
thank you.
So I think one of the things that really helps us in Louisiana is we have a very broad data sharing agreement between the Office of Public Health and Medicaid. So our original data share agreement was signed, I believe it was 2016. So we've had, a data sharing agreement in place for a number of years. And so really one of the first big projects we undertook was the data sharing for the HIV viral suppression measure, which we started calculating really that year. And I think we've really used our experience with that measure and the processes that we set up, to help us with some of our other quality measures, including the Hep C screening measure. Because, one of the problems is when you have, Medicaid in one, program. I mean, for us, Medicaid's in Baton Rouge, the Office of Public Health is in New Orleans. Prior to this data sharing agreement, we didn't have a lot of contact, but now that we're, actively sharing data, we know each other. We are all familiar with the University of Louisiana Monroe team that does all of the data calculations. And, we've set up secure ways of transferring data back and forth. And so I think, those are some of the things that have really helped us. And I think the other thing that's really helped us is to get buy-in at a high level. Herbert mentioned, we had some strong leadership that really was promoting Hep C elimination, but we also have a lot of buy-in from, each of the medical directors at Medicaid, along with the medical directors and leadership at the Office of Public Health, and really making them aware of the importance of the measure, and also providing them with data so that they can see that we're using the measures. I think those are some of the things that have helped us.
This is Emily in Washington. I would just add, in terms of our experience with data sharing agreements in Washington, DOH and Healthcare Authority have a great working relationship. And practically, those data sharing agreements are treated sort of like contracts or interagency agreements, and they take a long time to get through both sides of the house, through our bureaucracies. So I think that's just one initial challenge, is the time it takes to get those established, and then they have to be renewed, right? They don't last forever. And then, I'm not the person that does the data matching. If that person was here, I think they'd have a lot to say. But matching Medicaid data and surveillance data does not happen magically. It takes quite a bit of work. Names may not be exactly the same. Birth dates might have a typo. It's a really complicated process to match those some of it can be done through automation, but a lot of it is just a person looking through them. So it's not a very efficient way, at least in our state, of understanding what is going on with hepatitis C. And then, frankly, hepatitis C surveillance does not have the same level of resourcing as HIV surveillance, for example. And so I think some of that data matching between Medicaid and HIV surveillance is easier just because there's more folks to do the work, right? So I think that's a real challenge we have, is just a lack of infrastructure for doing that data matching and the data cleaning that's involved.
And this is Matt. I can, bring in Michigan's perspective, and maybe it's a little bit of a contrast with some of the other states. Data sharing agreements didn't particularly factor in as a challenge that needed to be surmounted in Michigan. So our public health administration and Medicaid are both under the same roof. We both have access to the same data warehouse. So that data relationship is kind of pre-existing. And then again, we have all process measures that are just using encounters data from the Medicaid health plan. So when that data gets submitted to the state from the health plans, it belongs to us. So we're able to take that data and calculate the quality performance on those.
So your recommendation would be for all the states to drastically redesign their infrastructure and put Medicaid and public health under the same roof. Takes 2 minutes, right? I know some of the other panelists here have reflections on data sharing agreements, and it would be terrific to hear about some of those as well, where it isn't possible to have the setup in Michigan.
So just real quickly, and I'll let Paloma or Nicole talk a little bit more. I think one thing that we've thought about here in the AIDS Institute, because we do have HIV, STIs, and hepatitis C under the same umbrella, is doing one data use agreement or data sharing agreement that covers all three, so that we're not doing piecemeal separate data use agreements to try to make things a little bit more efficiency, because like Emily said, it takes a very long time to go through the bureaucratic process to get a data use agreement signed. And then in New York, the other challenge we have is that we do have to have data use agreements with New York City Department of Health because they have a separate hepatitis surveillance system.
That's a very important point, is we have two sort of competing entities in New York. They're not supposed to be competing, but sometimes that's what happens. We have a really robust clinical data mart. Colleen mentioned this before, if anything, like, okay, snap of the fingers, we've spent 15 years building this Medicaid data warehouse and a clinical data mart and have support for programming measures. And so that's a place where we can leverage some of these big data sources. And that's where it's a little complicated, but like I bridge the gap sometimes between the AIDS Institute and the Office of Health Insurance Programs and Medicaid, and helping to bring those conversations together. Of course, they have their own analysts too at the AIDS Institute. We have a burgeoning all-payer database where all commercial payers are submitting claims as well. We have resources to program there, and this is a place where I would actually explore this as well. And then our health information network is robust in that we could pull out some additional lab values from our Shiny. And I will just say, in terms of other lab value codes on claims, like CP2 codes, we really tried to push that for controlling blood pressure in New York. It did not work. So I'm a little hesitant to say the way to do this is to get a code on a claim, because we have not seen that come to fruition fully yet. Just some piecemeal thoughts to throw out there.
Right. And you have another fairly unique leg up in that you are able to utilize your HIE for some of that clinical data. I'd love for us to come back to that as well.
Yeah.
Okay, anyone that we haven't heard from who really wants to make sure that you've imparted some of the practicalities and logistics about how to make these measures happen with those who are on the line today? Okay, well, we're about 5 minutes away from trying to start our questions and answers. And I know that there's a lot of chat in the thread that we'll be able to get to. One last question before we do go to Q&A. I'd love to talk a little bit with all of you gathered today about what you're really seeing in terms of impact and use of the measures. Please tell us a little bit about what are the insights that you are getting from these measures. And even though you've talked about some of those insights so far, I'd really love to hear about not only how you, but other stakeholders in your states apply them. I would like this to be the opportunity to come back to how measures are used in relation to the MCOs in your program, and how, if at all, you are setting benchmarks and incentives related to the MCO performance on your measures. But even broader than just MCOs, are there other stakeholders that you know in your state have really started looking to these measures as something that they can use and they can point to inform their own work? Let's go bottom up again. Washington, anything that you'd like to add to this discussion around your experience, even thinking about the measures that are recommended by the BREE Collaborative?
Yeah, Laura, I'm actually thinking you may be better able to respond in terms of your experience with the measures and the Medicaid, the contracts with the MCOs.
Yeah,
just
absolutely.
more broadly, since we haven't implemented these yet.
Yeah, so I'll use the similar approach with HIV viral load suppression measure. It seems to be going down a similar path as that one. A lot of times when we add a measure to the common measure set, it doesn't automatically get added to the MCO contracts because a lot of it depends on feasibility of reporting, especially if we're using a homegrown measure. So I know one way to manage that is to add it to the common measure set as just statewide reporting only, and we share that data with the MCOs. But I do think there's always an opportunity within our MCO contracts to implement a performance improvement project or something that focuses on a particular topic. We're currently looking at what the state priorities are and how to address those within our contracts. We do find that through our performance measures coordinating committee, which includes the MCOs in our state, that there's usually a lot of collaboration that occurs outside of the contract anyway. So I think there's definitely options here. I think the first thing is nailing down what is the right measure and how feasible is it to have our MCOs measure that versus maybe having a national measure that's in use more broadly that we could potentially adopt. So there's definitely pathways. I just think we have to take it one step at a time and identify what is a good measure that we could start with, and then what are the opportunities within our quality programs and initiatives. And along with that, where's the data source coming from? Because that's really important as to how we put it in our MCO contracts. I don't know if that helps.
Absolutely. Pennsylvania, please share your thoughts. How are your measures used? How I know you've had some interaction with MCOs on them as well. And are there any other stakeholders in your state who use them?
So, oh, go ahead, Lauren. Oh, go ahead.
I'll pass it to you shortly, but I just wanted to say that I think the availability of data more recently has allowed us to really get the MCOs together, have discussions about where we're at, because we have hard data to look at, which has been critical. And then we've also had the University of Pittsburgh partners share those data with our Hep-Free PA Coalition, and those coalition partners have been really happy to see some of those data as well. And then more recently, we've brought the MCOs and our Hep-Free PA leadership together to talk about actionable next steps, which has been really great. And again, to have those benchmarks available to us has been so critical. Go ahead, Dr. Kelly, sorry.
I was just going to say feasibility, but then things need to be actionable. And as Lauren described, we have our MCOs and our provider stakeholders and CBOs, community-based organization stakeholders, really, I think, aligned. And again, I think if you just focus on SVR 12, and I don't want to downplay that, you're missing the big picture. So, you know, in our data, we were looking at, I think, 13 or 14,000 folks that screened positive. in a given calendar year, but you know, only 4,000 or so were getting treated. So if you're just looking at SVR, you're missing that cascade picture. And the fact that our screening rates are very low. So if you just take that narrow approach, that's why we wanted to get this broader approach so that our stakeholders, our MCOs, and the providers could look at this. So we've had a lot of discussion about how can we do education. We also, by county, we identified how many providers were actually prescribing. And we found that I think close to a third of them were mid-level. So it's like our message was, if mid-level providers are prescribing, why can't physicians more widely prescribe? So we did, you know, really kind of a county by county analysis. So you have to look at the measures, but what actions are you going to take with those measures? Because that's really what drives quality improvement. And that's where I think it's really important in working with our MCOs and our stakeholders. Now, I did mention we had incentives, an incentive with our MCOs to get that SVR12 to look for cure. I think that has worked. Prior to that, we actually put them at downside risk for 20% of the cost of the drug. So first we started with kind of a downside penalty, but then we added an incentive. Our recent discussion with our stakeholders, it was interested. I don't think there was a huge amount of enthusiasm for provider or patient incentives, but it's certainly something that I think we want to pursue and look at that a little bit more. And then one final comment that was really interesting from one of our, I consider her one of our treating provider experts and really champion statewide. She's like, I don't really care about SVR12 at this point. I want to get people treated, and Medicaid got rid of their prior auth. I'm happy about that. Let's get people treated, get them through typically, you know, 2 months of treatment. And I'm going to bet that 90-some% of the time they're getting the cure. So it's just really important to have that multi-stakeholder feedback.
Mm-hmm. Thanks for those comments. Let's hear from the other states: Louisiana, Michigan, New York. Anything you'd want us to know about your approach to using measures in conversations and in contracts with your MCOs? And are there any other stakeholders out there using your measures?
Yeah, this is Herbert from Louisiana. For us in Louisiana, we created an MCO quality dashboard that displays our measures, including hepatitis C screening measure. We also put some language in the Medicaid quality strategy. That language is also available to the public as well. And one of the other things I wanted to mention that Pennsylvania mentioned, I think in my experience, some of the incentive measures happen to perform better than monitored measures. The HIV viral load suppression, we currently have 11 incentive measures in our measure set. HIV is one of them, HIV viral load suppression. But if the hepatitis C screening was to be added under the incentive measures, I think the rates will be in the roof because most of the MCOs tend to drive when it's driven by money. I don't know why. The other thing as well, in 2022, we implemented a performance improvement project on improving chronic hepatitis C pharmaceutical treatment initiative. And the MCOs with their case managers, care coordinators were tasked to linking members with a probable or confirmed hepatitis C diagnosis to their providers for treatment. And then also they were tasked to educate the providers as well. And they did all kind of cool stuff as well there. So yeah, that's, I don't know if Debbie and Lisa have anything to add. Yeah.
One quick follow-up question. You mentioned the Medicaid MCO quality dashboard. Is that publicly available?
Yeah, I'll put it in the chat. But just to note, we currently have measurement year 2021 data. I'm currently working on measurement year 2022. It's under validation, but we have the data. For the hepatitis C, I think we have only one. I think we have only 1 year, which is measurement year 2021. But we already have data for measurement year 2022. And the rate for 2022 data, it's a little up by maybe 2 points. So the MCOs are making improvement there. Yeah.
Mm-hmm. Great, thank you. And it would be terrific to get a glimpse of that. And I welcome others, either on our panel or in other states, who have any sort of public-facing mechanisms of sharing your measures, to put those in the chat and share your examples with us. Let's go to Michigan. I know that you also have engagement with your MCOs around these measures. We'd love to hear more about it.
Yeah, I was going to say our Medicaid health plans have done both provider and member education and outreach. So for providers, I know they've done in-service days just to kind of go over some of the changes to the removal of restrictions and I guess just the best way to go about treating Medicaid beneficiaries for hepatitis C. There's like newsletters that they've where they've provided some information to providers in those among those particular Medicaid health plans. And then from like a member outreach and education perspective, I think anybody that has an active hepatitis C diagnosis and no record of treatment, I think there was some care management outreach that was going on there. And so just having some of those, using some of that claims data as a result of, these new hepatitis C specific quality measures, I think it spurred a lot of changes in how they provide education both to providers within the Medicaid health plan and the members of the Medicaid health plan.
Mm-hmm. That's great. That's great. Any other comments from the panel before we open up to a question and answer with the audience?
I'll just say that 80% of our Medicaid members are in a value-based payment contract. And then we have a corresponding quality incentive with similar measures. And just to note that this would be broadly interesting to include this as a contracted measure. And there's a pathway to do that. And that's one way we really move the needle.
Mm-hmm.
We have the ability to say you have to pick from these categories for the measure. So that gets us a lot of action with the MCOs.
Well, thank you. We have covered a lot of ground. At this time, what I would like to do is take a little over 10 minutes to do our Q&A. We have in our agenda taking a break from 2:30 Eastern to 2:40 Eastern. So I'm going to commit with that so that we get the full 10 minutes after a short break for our first break. But what I would like to say is that when we come back, we are going to have another discussion with you, our panelists, that really takes shape around what you would recommend based on the experience that you've talked about here today. So with that in mind, I'm going to enter us into our Q&A session. Again, we'll take about 10 minutes here before we break. And what I'd like to do is start with a question that has to do with your experience related to the HIV viral load suppression measure. What I'd like to do is, since we have had a lot of questions in the chat about it, what I'd like to do is ask about how for those of you who are reporting in the adult core set, the HIV viral load suppression, how have your lessons learned in reporting that measure shaped your thinking around an outcomes measure for viral hepatitis? And I'd like you, I know it's really difficult to scroll through all the chat, but I'll call out one commenter in particular who said, for those of you who are capturing negative hepatitis C RNA results, are you thinking of those as a proxy for progress to elimination? So let's talk a little bit about really looking at data sources for outcomes measures using our experience with the HIV viral load suppression measure as a guide here. Is there anyone who would like to begin?
This is Matt Seeger from Michigan. I can kick us off. So Michigan has been reporting on the HIV viral load suppression core set measure for at least the last couple of years. Again, you know, our Medicaid and public health areas being under one roof, you know, have a really great relationship. So we're able to get that. Our Medicaid team is able to get that lab data from our public health team so that we're able to do that core set reporting. The way the data is integrated into the data warehouse, I think there's some level of integration. My colleague Jeff, I think, is able to speak more to that than I am, but it's been somewhat of a manual process, is my understanding, of getting that data for the viral load suppression measure and uploading it into the data warehouse, but it hasn't really been too cumbersome overall. I'll say that. The other parallel that I would draw just quickly, and maybe this is going a little bit off topic, but the other parallel I draw quickly between this and the viral load suppression is that Michigan is gearing up to benchmarking our MCOs on the viral load suppression measure, like I heard from a couple of the other state Medicaid agencies. What we've been doing the last couple of fiscal years is actually doing what we call a HIV provider outreach project, where we're asking our Medicaid organizations to build relationships with public health, the local public health agencies and the Ryan White organizations, so they can work together to develop a strategy for viral load suppression. And then effective FY26, we'll actually start benchmarking our MCOs on the measure. And I imagine we would take ultimately a similar approach with hepatitis C once there's a national standard measure.
Thanks, Matt.
I was just going to say, I can just
Yeah.
add that we do receive negative hepatitis C lab results in Michigan. And so, you know, from a surveillance, you know, perspective, it's separate from, you know, our Medicaid claims, but we're trying to, you know, through data sharing agreements, you know, be able to share that between, you know, like the Medicaid data warehouse and our surveillance registry in Michigan. And so being able to inform on a patient level, you know, who is still in need of treatment, who's received, you know, negative or who has negative laboratory results. And so, yeah, just kind of being able to speak better between systems, I think, is our next goal in Michigan.
Yeah,
We also collect negative hepatitis C RNA test results in New York State and do use them to track elimination. And we will soon be collecting negative antibody test results as well to look at testing rates and any sort of disparities around testing rates. But it's somewhat helpful to look at, to have the negative RNA test results, to use them as a proxy for someone who has either cleared infection on their own or who has been treated and cured. We'd like to validate that using Medicaid data, where we can look at claims data to determine whether or not these individuals have truly been treated.
Thanks, Colleen. How about other states reporting? Yes,
I'll
please.
just add, you know, I think the HIV viral suppression data is much more mature than our negative Hep C RNA reporting. And so there's a lot more information to draw from. HIV data tends to also be more complete in terms of risk factors, demographics. We have a lot of missingness in our hepatitis C surveillance data. So I think, you know, and lab reports often only include date of birth and gender is usually a binary male female. So lab reports don't offer a ton of insights. So I think in terms of using our negative RNA reporting in Washington to tell a story about anything, it's going to take us several years of that requirement being in place before we can do anything of use with that information. I think right now we still are really far behind in terms of, you know, when you look at our ability to track HIV viral suppression data and use that for public health action, our hepatitis data is just not even close.
Yeah, and I will I totally agree with everything you're saying. We mandated reporting of all negative Hep C results in 2019. And it has taken us several years to really get all the labs on board. And there are still some, you know, small labs that aren't sending us negative results. So I think it also, you know, we just don't have the capacity to data manage the negative results like we do with the positive results. We have data managers that do spend a lot of time, like you mentioned, getting missing information, validating labs, looking at issues that we just don't have the time to do with the negatives. But that said, we are using, like New York mentioned, we are using the negative data, and we do have a treatment dashboard as well that, Lisa, maybe you can put in the chat, that's looking at our HCV elimination plan in both Medicaid and corrections. And yes, we do use the negative results for, to see who has been cured. And then another thing I wanted to mention that we learned from the HIV viral suppression measure is it's important to put procedures in place, automate as much as possible, and document everything. Since we've been doing the HIV viral suppression measure so long, we've had a lot of staff turnover. And so it's really important to, we create very detailed SAS programs to do the matching. And so when we get and with a lot of documentation, so then when we get a new staff person, they're able to continue to calculate the measure in a consistent way so that things aren't changing from year to year. So I think that's an important thing that we learned with the HIV viral suppression measure.
Yeah, just to add on a little bit of what Debbie's saying, there's what's missing from Debbie's a little bit of stakeholder engagement within the different sister agencies. So with the Office of Public Health and Medicaid, we are just intertwined in terms of collaborating, deep in the data and also on different programs. So yeah, the other thing I wanted to say that in 2023, we have also implemented the HIV viral load screening performance improvement project. So that's ongoing right now with the MCOs as well. So I just wanted to mention that. And then also HIV is an incentive measure this time around.
That's fantastic. Any other states who would like to speak about their experience? I know that we'll be coming back to this in panel number 2, but before we break, there's one question in the chat I'd like to ask, but before I go there, any other states on the HIV viral suppression measure? Knowing we have more to come there. We did receive a question in the chat from Lauren Sant. How many FTEs does this really take? Is anyone from the panel willing to tell us a little bit about what your operations look like in terms of implementing and reporting your measure? Debbie, you just gave a very, very helpful practical advice with doing documentation, having processes in place, thinking about what the next person needs to know. So any comments from the panel before we break on what the teams sitting behind you look like and what those numbers look like for you? Ranges are fine if you don't want to be specific.
In Michigan Medicaid, and I'm not sure if we're still talking about HIV viral load suppression or our custom Hep C measures, but it's really, in either case, it's one analyst. So we have one analyst in Michigan Medicaid who's responsible for doing the adult core set reporting. They do work with some other individuals to gather some information, so maybe that inflates it just a little bit, but we really have one subject matter expert who handles that, and same with the our 3 custom hepatitis C measures. We have one person. It's fairly automated because it's the claims data and the report largely generates itself, but we have one person who's responsible for making sure that report comes together the way it should, passing on the performance rates to the health plans.
In Pennsylvania, we again, we use our Medicaid Research Center, so we're not using state FTEs. There's a intergovernmental relationship with the University of Pittsburgh. So we rely on their expertise to run the data. So we have the ability, and like I said, we reran multiple years of data across multiple measures. So that we found that to be very, very efficient. It's not validated by, let's say, the EQRO, but it's actionable data. So So we don't have a lot of FTEs working on this. The other thing that we did around HIV, and I think we're still kind of internally deliberating this on Hep C, is that for HIV, we actually wrote an HIV dashboard, and we make our MCOs report that to us annually. So they run their data. We've given them the specs over the years. They run their data, and then we collate that. And again, we don't go through a big validation process, but again, we don't have FTEs that do that. And then we just rely on each MCO because they are closer to their claims and their claims data. So it's a way to do things without having a big budget.
Great. Anyone else want to weigh on that, on the teams helping you support this work, small and or mighty? Okay. Well, I'd like to thank the panel for all of their comments during the first set of the discussion that we'll have today. Let's take a 10-minute break. And we will reconvene at 2:40 Eastern and turn to the part of our discussion where we will be focusing on recommendations around an adult core set measure. Thank you all. See you in 10 minutes. All right, welcome back from the break, everyone. We are entering our last segment of our agenda today, and this is the segment that we're all really looking forward to, because this is when we're going to take all of the information that we've heard and start to get down to recommendations. I'll invite our panel to start turning on their camera, but let me go over a little bit of housekeeping for how we'll do this session first. We're going to do about 20 minutes of discussion with our panel and really start to have them start to think about and articulate the recommendations that they would have around an adult core set measure. And then what we would like to do is ask the audience that's here today to come off mute and to ask questions directly to the panelists. What we want to be able to do in this session is prepare all of you on the line to conduct a measure ranking experience. If you'll recall, in the presentation that Edna Boone gave in the first segment of the meeting, she displayed a set of measures. Now, those measures were hypothetical, and I believe they're just a few slides down. If you don't mind flipping to them, Zoom moderator. Thank you. One more down, perfect. So we will be looking at this set of measures and asking you, our audience gathered here today, to help us rank them and think about which measure you would propose for supporting in the adult core set. So the message to our audience is, use this time to start thinking about, what do you need to know from our panelists here today? What about their experience and what in their recommendations would lead you to support one of these measures? We'll make sure that this table is downloaded in the chat function for anyone who wants to be looking at it off to the side. And what I would like to do now is go ahead and turn back to our panelists. We'll start looking at your videos again. Thank you for coming back and joining us. And let's just take about 15, 20 minutes together to start setting up our recommendations. So what I'd like to do here is talk about an ideal state for you. In thinking about what you would recommend for an adult core set measure, what would you like to report that you are not currently reporting on? And as you think about an adult core set measure, is there anything that you have heard from the other states in our panel here today that you think would not be feasible in your state? And if so, why? Let me open that up to the floor for anyone who would like to begin.
I think in Michigan, at least, one thing that is maybe not unique to us, but we're focusing on hepatitis C quality measures because that's the majority of the funding that we receive is devoted to hepatitis C surveillance and prevention, and so we have state appropriated funding for that's dedicated for some of our local health departments and our syringe service programs to do hepatitis C linkage to care and treatment. We have the agreement in place to have a preferred DAA for our Medicaid beneficiaries. We have all these different reasons, I guess, for focusing on Hep C, but it totally makes sense to add Hep B screening, based off of those recommendations from CDC, and to add that along with any hepatitis C quality measure that we're currently doing.
You previewed the question that I wanted to ask as a follow-up to this. Let's go there, and then we'll take a step back again to think about anything. Can I ask our panelists to address what is something of an elephant in the room? With all of the focus on Hep C, what are the factors or limitations or motivators that have led you to really focus on Hep C measures instead of Hep B? We just heard from Michigan. Can anyone else help us address that question?
I think from Pennsylvania's standpoint, we are looking at both Hep B and C. Hep C is probably more of a focus because from a budgetary standpoint, um, the treatment costs us quite a bit. So we want to make sure that folks get through treatment and get to cure. But we have been actually measuring both Hep B and Hep C. Now with Hep B, we're only doing the screening part, and who's out of that who's tested positive as best we can tell from claims data. But we're very focused in our uh, opioid use disorder center of excellence program. Hep B, C, and HIV are all quality measures for screening. So I know I've talked mostly about Hep C, but we're not just focused on that. But it is from a quality of care standpoint, and having been part of the adult core set since it started, as far as making recommendations. I mean, really, you need a measure that is going to be feasible and actionable. So you can't ask for too much, I don't think, or do too many things. So to say that, well, let's do Hep B and C, and let's do screening, treatment, and SVR12 for at least for Hep C and screening and perhaps treatment for Hep B. I would just say that's too much to take on all at once. And I think that the advisory panel would worry, especially if there's not a lot of state experience in being able to make this feasible. And then what's actionable? I mean, from a Hep B standpoint, I mean, we have a very effective vaccine that has been around for a very long time. And but so I don't think we should be just focusing on Hep C, but I think we probably need to, just from a practical standpoint, is focus on one or the other. I think to say, well, let's do both Hep B and C, and let's do screening and treatment. I think that's probably asking too much. I would advocate really for a kind of a bundled cascade of treatment. Screen, who screen positive, and then treatment. And the difficult thing would be to get to the SVR12 for us anyway. And the HIV viral load is it's one of the few that we as a state have not been able to report for multiple reasons.
Mm-hmm. Thank you, David, for those comments. A lot to come back to. Yes, I think was that Laura?
No, it was Colleen. So I mean, I
Thanks,
echo
Colleen.
a lot of what David said, especially the bundling. I do wish we could capture treatment initiation because I do think that's actionable, and super important. And as we start to build out protocols for data to care, we've done a lot of work in New York with managed care plans and feeding data back to them on individuals who appear to be out of care or unsuppressed. We'd like to do something very similar for Hep C, and we should because it's curable. And I don't think there's any better motivator than that. So I do agree with testing, treatment initiation. SVR12, honestly, I hope SVR12 goes away, or becomes SVR4. It's impossible. It's impossible to collect that. And these treatments are so highly curative. I really hope to see a change in clinical guidelines away from SVR12.
And while we have you on, Colleen, let's take a moment also on Hep B. Is there what in your sense has led to the emphasis of measurement around Hep C over Hep B? Does it relate to some of what you said about the bundle and knowing that at the end we don't have a cure yet for Hep B, but there is a vaccine?
So I think there's a lot of things. I mean, Hep B, except for surveillance, Hep B, like perinatal Hep B and vaccine for adults program sits outside the AIDS Institute where I am. So that's one issue. The other thing too is that we don't have a lot of infrastructure around Hep B programs. So that's another reason. And the other thing too is our elimination plan is focused on Hep C. So I think those are some of the reasons why we don't focus on Hep B. At least I don't, maybe Paloma knows, but because we don't focus our work in the AIDS Institute on vaccination or perinatal Hep B, perhaps there is something around Hep B.
Thanks.
I don't think there is. Just one other quick thing. I think it would be great to see a performance measure on anyone who has opioid use disorder diagnosis and Hep C screening. Again, that is the population most impacted by Hep C, as everyone on this call knows today. So something along those lines, and we need to do more to motivate our addiction specialists, behavioral health programs to do Hep C testing.
Thanks for that
Yeah, this is
addition.
Dave
How about
Kelly.
states?
Just to follow
go
up on
ahead.
that, I know that we participate in a multi-state effort to look at opiate use disorder treatment quality measures. I think that multi-state effort has looked at screening and within that population for Hep B, C, and I think HIV. And I will tell you, there's huge room for improvement within that very high risk population. So again, I think from a core set standpoint, I think we're always looking for how can we more broadly put measures in place that affect a large population. So the last time we ran data, we had over 160,000 people got screened, 12,000 or 13,000 tested positive, but only 4,000 got treated. So I would really advocate for a measure that gives you that cascade snapshot and not necessarily just the outcome, because I think you're missing the boat.
I agree with David on that. Being our state representative for the CMS core measure set reporting. I do think, though, on little conservative side, you do have to start somewhere. And if states aren't even screening, that would be a good place to start with the intention of moving towards outcomes, of understanding what was the result of that testing. As a state, it's our goal to really start moving towards those more outcomes-based measures, but this is not something we are currently tracking per se on our measure set. So as much as I hate to say it, I think we have to start somewhere.
I'm going to come back in a moment and ask a focused question around recommendations. But before we do that, just to close the loop on Hep B versus Hep C. So we heard from New York, we heard from Pennsylvania. Are there any other states on the line who would like to weigh in on their thoughts and reflections on the emphasis on Hep C funding? And in particular, any arguments that you would want to make around Hep B measure?
What Colleen mentioned, I think, is very true for Washington in terms of why we focused on hepatitis C. Also, our initiative around elimination came from a directive from our governor, which was specific to hepatitis C. I think a measure that looked at Hep B and Hep C screening could make a lot of sense. In our state, viral hepatitis has been pretty siloed. So Hep B lives in a different place than Hep C in our public health bureaucracy. That may be changing, and I think that will offer a lot of efficiency and will help bolster the work generally. But that's sort of traditionally been the case, as well as the perinatal Hep B program, which lives in a third section. So I think bringing those together can give us a little more coherence around our response. But I think when we're trying to do a lot with very little, we had to prioritize, and there is so little infrastructure for viral hepatitis in public health. We've tried to focus the limited resources we have on where the burden is greatest, and that really is in Washington. Hepatitis C has a much higher burden than hepatitis B as far as we can tell. And our data is not great, but it's pretty good. And so from what we can gather, that the greatest burden of viral hepatitis in our state is hepatitis C. So, as my father likes to say, when everything's a priority, nothing is a priority. We've had to make some prioritization, but I do think looking at a joint measure around screening for B and C could make a lot of sense and doesn't feel, at least from my perspective, like it would be that hard to do.
Yeah, that's great. Okay, thanks. So thank you for adding that. Is there anything that anyone from Louisiana anything that anyone from Michigan would like to add to the conversation around Hep B and versus Hep C before we move on to other recommendations that you'd offer?
And Nicole, this is Hubbard from Louisiana. Yeah, I was going to say that I think it's also imperative to understand the landscape of the state. In Louisiana for hepatitis C, I think by then there was an influx in the correctional department of hepatitis C. And then also there was a high risk of acquiring Hep C through injection drug use. The numbers were high in Louisiana. And then, of course, also based on the literature by then, there were high rates of liver cancers driven by hepatitis B and also C. But then the state, like one of the panelists was sharing, in terms of prioritizing, they decided to go with hepatitis C. But I think there is need to also, I think there is room to also include hepatitis B moving forward. There has also been push around, like I shared previously, we had a performance improvement project on hepatitis C pharmaceutical treatment initiation that we did in 2022. The other thing I wanted to mention also, I think David mentioned it, I think bundling would be a good idea as well. I think I like that as well. But sometimes I think some of the challenges we face, are just kind of leadership. If leadership, like Debbie was saying, in Louisiana, we had a lot of buy-in from leadership. Our chief medical officer was interested in hepatitis C. That kind of helped drive that move, and also the secretary, Dr. Rebecca Gear as well.
Okay, Michigan, anything to add to Hep B versus Hep C? And if not, that's fine. We'll keep moving on.
Okay. No, I mean, I just will echo what everybody else has said about, including the Hep B screening, I think makes sense. From talking with Matt and over the course of the last few years, we have the process in place for developing these Hep C quality measures. And from what Matt said, it was pretty easy for his section to get that implemented and evaluated. And so I think, if we do decide on, including some more, I don't anticipate that being too much of a heavy lift for our program, at least.
So we will come back to the topic of Hep B one more time when we look at the list of measures, because when we ask the group assembled here today to help us think through the value and feasibility of some of the proposed measures for discussion here today, we will be looking at a Hep B screening measure. So let me give a cue to the audience to know that we're going to be asking for your opinion and to hear your voice too in this conversation. I have two last warm-up questions for our panel before we're going to ask them to give their hard recommendation if they only had to choose one measure. Let's take two topics before that. So we've heard a lot about the available data set. What I would like to ask is, how would in kind of a quick lightning round, how much would your current data set, thinking about who has access to labs, who has access to claims data, how would that current data set influence your recommendation to pursue an outcomes measure versus a process measure? I'm going to make this kind of quick. If everyone can give an answer in about 30 seconds, that would be great. Let's go from top to bottom and start with Louisiana again.
I think with the data sets that we have, that doing an outcome measure should be not a problem, because we do get the negatives and we do the SVR already, so I think it should be okay for us.
Now, if you did not have that, would you say, okay, I have claims data, And because I only have claims data, I'm going to support a measure that focuses more on screening? Or would you be sitting in your position as one of many states that might be on the phone call listening today and saying, I'm going to instead focus on getting that data that supports an outcomes measure?
I think I would go with what I have available to determine what measure I would go for.
Great. That's very, very helpful. Anyone else from Louisiana, would you modify or add to that? Okay.
I think we also
Oh,
mentioned.
yes, Herbert.
Sorry, no, I think also stakeholder. I think the engagement of our partners as well. Lisa is with the Office of Public Health. I'm with Medicaid, but also we have the University of Louisiana Monroe. I think also David from Pennsylvania was mentioning some of the groups they use for mining the data. I think it's just trying to understand what are the resources that you have, that can save you money.
Mm-hmm. Okay, great. Turning to Michigan, I'm going to put a twist on the question. So again, thinking about the role that your data sources play, if you had to only pick one measure, how would your data sources play a role? And in particular for you, since you do have data that you're using as a proxy for outcomes, how does the availability of that data make a difference to you in recommending a measure? Are you content with the data that you have, knowing that that you're not looking at clinical data, you're looking at administrative data that serves as a proxy?
Yeah, no, I think, we're in a similar situation to Louisiana in that we get those negative lab results and eventually we've started this process through data sharing agreements, but we'd like to get, our laboratory data to send that to, Medicaid data warehouse, have them speak to each other to supplement the different activities that are going on, because there's care management occurring, with using the data warehouse Medicaid claims data. There's case investigation that's happening at the surveillance level with some of our DIS, local health departments doing patient navigation. So, getting those to supplement each other and knowing that there's limitations to that data, I think that's where our vision is in Michigan, and just trying to develop and improve upon, some of the work and quality measures that we already have in place, and just kind of continue to share that data across programs.
And I'm gonna maybe break the rules a little bit and throw in an additional Michigan perspective. And it's great to have Jeff here, kind of bringing the public health perspectives bear. And I agree with him that we want to get there. If you made me pick real quick though, what I'd like to see in the CMS core set, a measure that I would probably say in the immediate future, I would much prefer to see a process measure. It's a lot of work to report on, Jeff was just describing the work that it'll take to get to where we could report on an outcomes measure. I don't think we're there yet. There's a lot of federal requirements for state Medicaid agencies. If, the 10% of people on the line who are from Medicaid are probably familiar with their MACPAR reporting, which has really been heating up lately. Between that and the CMS core measure reporting, it's a lot of work to get all those measures over to CMS. And the claims-based measure is something that we can get very accurate and very quickly, and it's easy to compare with the other states. And I'd also like to emphasize that it's meaningful. If you're getting your members screened for hepatitis C, then I think in most cases that will pretty inevitably lead to treatment. So I'm with Jeff that I think we're on the right path to get there, but I would start with something that we could input just based on that administrative data.
I guess I wouldn't be so quick to assume that it's going to lead to treatment, especially in some settings, though, Matt. I have to say, I wish I had your optimism.
So Colleen, what would you pick if you were selecting a measure? And I'm going to ask a question next about how the emergence of more clinical data from EHRs and health information exchanges will affect this landscape. But if you had to choose right now, let's just go ahead and move into that, where we'll ask each panelist to respond. What would you pick right now, Colleen?
It's so hard, right? Because I mean, you do have to screen in order to start treatment, right? And so, but you know, when we look at data for elimination, we're only at 50% of people who are diagnosed with Hep C in New York State, and that includes New York City, that have either been have cleared infection through treatment or spontaneously cleared. So we have a ton of work to do over the next 6 years around elimination. So I'm kind of feeling like treatment initiation, but it's a really tough call, Nicole, for sure.
It is. It is. How about others from New York before we move to another state? Anyone want to put their vote in for
I think I'm torn.
process?
I think this must be similar, like Colleen's program, and I'm like, we're gonna have to actually program this, and we want process, we want outcome measures.
You want both.
We want to do these things well. I'm hesitant to land one way. I'm sorry, but maybe that's part of it, part of an answer.
That is fair. Colleen, you spoke. I think I don't see our third New York panelist, Nicole, on the line, but Nicole, feel free to add your voice if you'd like. Let's go back up to Michigan. So Jeff, we had Matt on the record saying that he would endorse a process measure. If you were choosing, would you put your weight behind process or outcomes?
I mean, if we had an easy way to get those outcomes, I think that would not be an issue. But I think, like Matt said, I think that looking at that claims data and the process, and we use it, you know, treatment initiation, you know, with our surveillance data as like a proxy, you know, a lot of times, because a lot of times we're just not able to get that that follow up with the SVR12. So there are limitations. I guess I would go, yeah, lean process. If I had to, I'd like to have an outcome if that were possible, but I think just with the limitations with our system here, maybe I would go with that.
Yeah. Okay, let's turn to Pennsylvania. David and Lauren, putting you on the spot with 15 seconds each to give your answer. What would you choose, process or outcomes? Would you go more for a screening measure, screening plus treatment initiation, or outcomes?
I would do screening plus treatment. And again, I think because when you're drawing up the specs, it's very similar. It's administratively, you're looking at the same query runs basically. So I think that instead of just doing screening, I think to go for the treatment part of the cascade is really important. The SVR, again, very difficult. I've talked to a lot of other states, lots of challenges. I wish I was in Michigan or Louisiana, where I had that data accessibility. EHR data, it's a dream. It's just not reality yet. And I deal with this on a lot of other quality metrics like hemoglobin A1Cs and blood pressures.
Yeah.
We're not able to do that. So yeah, that I would lean towards a combined screening treatment. Administrative.
Great. Lauren, how about you?
Yeah, I agree, especially with the data limitations on the outcome side.
Okay. All right. Pennsylvania spoken. How about you, Washington? And then we'll go back up to Louisiana.
I think I'm mostly dittoing what others have said, but I don't see a realistic pathway to an outcome measure that we can actually track with fidelity. So I think a process measure, and for Washington, we estimate that 80% of people with Hep C know their status. So if I had to pick one, I would lean towards a treatment measure. And I appreciate that may not be true everywhere. And to Colleen's point, you have to test people before you can get them treated. So if we could have our ideal, it would obviously for me be both. But if I had to choose one, for us at least, a treatment measure is where we have a lot more work to do. That's where our cascade falls apart. It's not around the screening and diagnosis. It's really getting folks from knowing they have Hep C to getting cured.
Okay.
Yeah,
Laura,
I agree
what are
with
your
Emily.
reactions?
I would just add that, if we can't report it to CMS because we don't have the data, then it's not meaningful. So agree with the idea of bundling a treatment and a screening measure.
Okay, great. Louisiana, we have 3 of you, but I'll ask you to, in a fairly quick fashion, please react to what you've heard. Would you endorse, given your current state, a measure that would be screening plus treatment initiation, or outcomes?
I would say screening plus treatment initiation. Even though we can do the outcome measure, I think it's way too soon. It needs to be piloted in a few states that have good data for a while. So I feel like it's too soon to do the outcome measure. So I agree, bundled screening and treatment.
Okay. Herbert,
I
I
agree.
see you nodding. Same answer? Same
Yeah, I
answer,
agree.
Lisa?
Yeah, I agree.
Okay. Okay, now I'm going to ask one more question before we turn to our poll and turn the question to our audience gathered here today. I made a reference a few moments ago that there is a groundswell of effort to make data available from EHRs and from health information exchanges. And we know New York, you have some experience there. If you think about how that effort is building, is there anything that would change your decision? If you had that data today, would that change your decision? And if it would, yeah, well, let's just start there. Why don't we start with Michigan again? If you did have access to that clinical data, would that change your vote for a process measure?
Yeah, I guess there's a lot of barriers in place to, get those things off the ground. And I don't know. I guess hypothetically it could potentially, but I think from what my conversation with Matt and, we're chatting on the side, just kind of going over our thoughts, and we both agree about the process, that bundle that everybody else has kind of mentioned is the best recommendation for a quality measure.
Okay, so current state, you would support that bundled screening plus treatment initiation. Yes. Now, if you had access to clinical data magically handed to you, barriers eliminated, would that then, for everything that we've talked about today, would that move you into the camp of saying, let's move beyond just treatment initiation, let's go to outcomes?
Yeah, I mean, that would, if that was a possibility, yeah, that would make sense, the next logical step. But yeah, I know it's just hard to get that data consistently.
Okay, how about the other states? New York, this is a little bit of an unfair question to you, but
yeah, but even
but what would you say?
We would have to lean on the plans to do this, to pick up their supplemental from their contracted health innovation networks, right? So it's from their HIEs. So I still think the first step would be treatment initiation, or sorry, screening and treatment, because I'd want to see what that looked like, how closely, like the external validation of the data, so that I could okay, is this getting close to what we think is happening in the real world?
Yeah.
And we're nowhere else with there's not a single other measure. There's so many other measures that would want to use that data. There's a follow-up for breast cancer screening coming out from NCQA. We'll have to lean on there. So we're going to get better at this, and we're going to leverage that. And so I do think it's a future state, not a current state.
Okay, well, that's really good to know, because what I think I heard you say, and I just want to clarify, is that even if you had that clinical data handed to you, you would still support a screening and treatment initiation measure because of the role it would play in your program.
Yeah.
Okay, Colleen, Nicole, anything you'd add or modify to that before we move to Pennsylvania?
Colleen.
I'm relieved that Paloma said yes to the bundle.
Look, I don't think I think it's going to be a weighed measure, and we'll have if we put this in a quality incentive.
Okay. David and Laura, turning to Pennsylvania. So if you had clinical data, would there still be value to a screening and treatment initiation measure in your state? Or would you put outcomes first?
I would say I would still want to see, I'd still want to see the other data. So as I said before, I got 12,000 people that screened positive. Last year, I only treated 4,000. If I'm just concentrating on the SVR12s for those 4,000, I'm looking at the trees. I'm not looking at the forest. From a population health standpoint and a Medicaid standpoint, it doesn't make sense to just look at the SVR 12. So even if I had it, I'd love to have it, and we actually do get it because we make our MCOs get it. So I have it, but I think it's more important to look more broadly.
And sorry, just to clarify the question, is this an or? Because I'd love it to be an and, I guess. But
well, everyone will have a chance to rank order their questions, but for those states who may be listening and find themselves in a similar position to Pennsylvania, what we're looking for is drawing out, even if you have the clinical data, would you be interested in, is there still value to a screening and treatment initiation measure to the effect that you would prioritize that measure in your state over an outcomes measure?
So the only other thing I guess I'd add is that I think I'd still maybe prioritize the process measure, because in our state currently, we really don't have any other way to look at that process measure. Maybe as some other states are further advanced in their care cascade development with their lab-based data, but it's been a slow go for us in Pennsylvania, and I know in many other states. So without the claims data, we really haven't been able to look at that.
And when you say process measure, are you talking about the standalone screening measure or the screening plus treatment initiation measure that starts to veer into proxy for outcomes?
The latter.
Okay, great. Any other states clarifying? Would any other states who've spoken want to clarify that? Anyone specifically who's put the endorsement on a screening and treatment initiation measure? Do you want to clarify any of the comments that you made specifically based on a standalone screening measure versus treatment plus initiation, screening plus treatment initiation? I think I see no. So Louisiana, let's come back to you with the hypothetical question of all things being equal, since you've got the clinical data, how do the measures, the hypothetical measures of screening plus treatment initiation and an SVR measure rank for you, considering their value in your state and other factors that we've talked about today? Is there one measure that you would put more weight behind and endorse?
Are you asking us to choose between treatment initiation and SVR?
Yes.
Yeah, I think I would still vote for the process measures over the outcome measure.
Okay. Okay. All right. Well, what I would like to do now, we are going to shift into the part of our agenda where we will turn it to the states. I would like to ask, and I'll ask for this with a raise of hands, are any of the audience members listening today, would they like to ask any clarifying questions of our panel before they themselves are asked to take a vote? And to put a very fine point on that, in a few moments, we'll be sending out a poll, and it's going to ask the questions that we've been talking about today. Which of these measures would you rank order? How valuable are they to you? So I'll ask to our audience, are there any questions that you would like to ask of our panelists before you are also asked to go through that exercise? I do see one hand raised, and if there are others, please do queue for us. Can I ask for Jules Levin to, you're welcome to turn on your audio, you're welcome to turn on your video, and we'd love to hear your question.
Hi, can you hear me?
We can.
Okay, so my question is for all the folks from the states. We know that hepatitis C is very prominent amongst a substance abuse disorder, injection drug use. And we know that opioid treatment programs, OTPs, funded by SAMHSA, which are all over the country. I think there are 150 in New York State. That's where a lot of these people live. But we also know that hepatitis C services in these OTP clinics are not really very prominent. So could you please talk about, would you be willing or are you planning to survey and measure the how many OTP programs in your state are providing hepatitis C services, screening, care, and linkage to treatment? Thank you.
This is Dave Kelly. Within Pennsylvania, I mentioned a couple of times we have what are called centers of excellence, which can be OTPs, but they can be OBOTs as well. And we actually measure the screening rates for Hep B, C, and HIV within those centers of excellence. And I can tell you that there's a lot of room for improvement. There's a very low percentage of the methadone treatment centers in Pennsylvania that actually offer treatment on site, and that's one of the things that we have a learning network and a technical assistance vendor partner that is actually working with us to, if we need to do boots on the ground, getting those both physical health and behavioral health centers of excellence vested in actually prescribing, screening, and treating within their clinical sites, and getting, during the provider portion of this, we heard about incorporating order sets, incorporating this into your everyday workflow. That is what we are going to be working on in 2024. We have 275 centers of excellence, and they see over 40,000 individuals living with opiate use disorder.
So in New York, we actually just surveyed our OTPs and our outpatient treatment programs, looking at Hep C infrastructure, and it looks like only about a third of them are doing treatment on site. So we do have, I agree with Jules, and I think, I think this is a complex question because it does involve, not DOH in New York, but our Office of Addiction Services and Supports, but it also involves SAMHSA as well. So I think we have a lot of work to do. There's a lot of complications in OTPs to try to get treatment up and going in terms of resources, in terms of billing and reimbursement, and in terms of the client population. So, but this is an area we definitely need to make improvements on, and this is why I think it's so important to include a Hep C screening measure in OTPs.
And I can just add from Washington, we've surveyed the OTPs with the help of our state opioid treatment authority, who also lives at the healthcare authority, not in Department of Health. And most of the OTPs are doing screening. Not very many are doing treatment. And I think it really comes down to the F word funding. They get a bundled rate per patient, and asking them to add a lot more clinical services is difficult. The other thing they brought up was space. That many of them just don't have space to be doing broader clinical services. So I agree, this is a really important setting for Hep C screening and testing, as well as Hep B screening, syphilis, HIV. I mean, there's a lot OTPs could and probably should be doing. But when the rubber hits the road, they are limited by the bundled rate they receive. And so I think we really need to look at that bundled rate and enrich it to add these services that people may not get elsewhere, right? We know they go to their opioid treatment program daily or maybe every 2 weeks. It's really a key spot, but I don't think the quality measures per se are going to solve the problem around that. I think it really does come down to resources.
So thanks for that discussion. We're going to go to Samuel. So next, thank you. You're all ready. And before we hear his question, I'll just mention again to our audience members here on the line, if there's anything that is a question you have before you are asked to also give your references, tee up that question here for our panelists. They're here to help you think through it. Okay.
Hey, thanks,
We'll
Nicole. This is Sam So from Stanford University. I have a question for Colleen, my friend Colleen, and Jeff from Michigan. You know, I noticed you introduced a quality measure for HCV screening in pregnant women. Do you have any plans to actually introduce a quality measure for HBsAg screening for in pregnant women? Because CDC estimates about 16% of Medicaid patients have not been screened antenatally for hepatitis B.
Hey, Sam, nice to see you. No, we do not have any plans at this point in time for Hep B surface antigen screening among pregnant people. You know, that's something that we could discuss with our Hep B program here at the department. And that's, you know, pretty horrible data that you just shared. So so much work is needed in that area as well.
Yeah, I was just gonna echo the same thoughts. You know, I don't think those conversations have started here in Michigan, but yeah, I'm hoping there'll be some more, you know, once we have some agreement here. After this call, there'll be some more Hep B related quality measures that we can implement and get those conversations going.
Yeah, that would be great. Thank you so much.
Nicole, I've opened up the line for Lynn Taylor.
Hey,
Thank you,
Colleen,
Lynn.
who is always an inspiration, and I respect your leadership and how you're always ahead of the curve. But I have a similar question to Sammy's in that, you know, Hep C diagnosis in pregnancy is a marker for injection drug use and opioid use disorder. So when we step back and think of the medical intervention, the most important medical intervention in a young woman of childbearing potential is not Hep C treatment. It's insignificant. This person's never going to get liver cancer. She's the most slow progressor of all. In the old days, we were told not to treat these people. The intervention is opioid agonist therapy to save her life, keep her from overdosing. So I am wondering if you've talked about this in New York. I understand if you want to camouflage the measure and other measures, but if it's the only measure, you know, you're identifying not people that are important to treat. Perinatal transmission rates are low. Most kids spontaneously clear their Hep C, and if not, you have highly effective drugs at age 3. The intervention there is to save her life and provide complications of opioid use disorder. So are you concerned, or have you talked about what you're really exposing? If this is the focus of all the Hep C work, you know, no matter how pharma is pushing the issue to treat in pregnancy, when you step back for the doctors and medical people who treat patients, the medical care of a young person with opioid use disorder who's pregnant is buprenorphine, methadone, care for addiction, so the person doesn't get a bloodborne infection, endocarditis, and die. And I hope I don't want my state, and I see someone from my state here, and I really respect, to make that the only measure, unless actually the plan for intervention is not about Hep C, but it's about, okay, you've identified someone who's at high risk of overdose, or because you're just a biologic marker for addiction. The Hep C, no matter, again, what Gilead has been funding and pushing for treatment of pregnancy, that is not really important in terms of what really matters in a young person of childbearing potential with Hep C. That's not the medical priority. So I'm wondering if those discussions have been had in New York, or if now you're going to make sure when you identify as this is a biologic marker of injection drug use, that really, when you go down that cascade, the intervention is methadone, OA, you know, ideally buprenorphine in pregnancy, and then finding the male impregnator, because a woman or person of other gender who's pregnant is just going to get reinfected. That's the bigger issue with transmission, rather than the very low rate of perinatal transmission with high rate of spontaneous clearance by the time the kid's 3. Has that been considered in that single measure in New York?
Yeah, so it's, you know, when we were even, you know, thinking about the legislation for universal screening among pregnant people, we talk a lot about substance use disorder in pregnant people in New York and our Office of Drug User Health, and work very closely with them. And it's policy in New York State for a verbal screen and not a biological test for substance use disorder for pregnant people. So it's incredibly complex. I feel like we could have a whole conversation about this, and we are starting to dig in a little bit deeper in New York, because we do have 60% of our female cases in women of childbearing age. So that's the population I think that we really need to focus on getting not only Hep C tested and treated, but also making sure that those individuals get medication for opioid use disorder. So it's not that we're singly focusing in on the testing. You're so right, Lynn, that we can't just look at that. We have to look at the whole individual. And medication for opioid use disorder, as you know, could be life or death. And so there are those conversations that are happening, that have been happening. We have some information in a provider toolkit that talks about working with pregnant people with substance use disorder. We have a lot of those resources available to providers as well. But obviously we have more work to be done, and we don't want hepatitis C to be that marker, because it's not just so much about getting medication for opioid use disorder. It's also the concern about that baby being taken away from the parent. So that's another concern as well. So it's incredibly complex, and I appreciate your comment.
Hey, Nicole, there is a question that came in through the panelists, or for the panelists, I just wanted to highlight. So we talked a little bit about data, and if you had data, would you move towards outcomes-based measures? And what I heard was resounding, not yet, even if the data is there. But a question from ONC, Michael Whitty, was asking about the information that is available in EHRs today. And is there any, do we think that there will be additional progress based on TEFCA? Do we think that some of the data was blocked, or do you feel as Medicaid agencies that you are receiving all of the data that is available to you?
So in Pennsylvania, I mean, our statewide e-health initiative sits within our same office. And I can tell, and we have kind of a confederated model. I'll just say the short answer is that information is not flowing from our health information exchange into the Medicaid agency directly. Some of it, we require our MCOs to actually be part of one of the health information organizations so that they are robustly getting more and more data. And we require our plans to do many of the NCQA, ECDS measures. With that being said, there's still a lack of data flow. Simple things like getting blood pressures for the HEDIS measure, hemoglobin A1C labs for the HEDIS measure. Even those simple things don't flow quickly. Now, with TEFCA and FHIR, I'm very optimistic. And I'm hoping that in the next year or two that a lot more information starts to flow from EHRs. One of our health plans really gets they're owned by a large health system, and they get some of the direct feeds from both the health information organization that they own and operate, but also from their EHR throughout their system. So some providers are very sophisticated and can send that, but it's not widely available, at least not in Pennsylvania. And we have a statewide system and 5 HIOs, and we're linked to multiple states. So we're not that far behind anybody else in the electronic exchange world. There's some other states that are much further ahead, like probably New York.
Oh, geez. I don't have the statewide health information network person here to talk about the robustness of the data. From the quality measure perspective, yes, we do every single electronic clinical data measure that NCQA puts out. How well the plan, again, and not to say we push the plans to do so much in New York. Just want to put that out there. but I would still require them to go and pull from their contracted Shiny in order to pull this data. I don't know how well it would be done for this because, and like David said, CP controlling blood pressure labs are not coming through. And that was a huge push with like tons of effort and money. So I'm concerned it wouldn't come back to us in a way that would be meaningful. That is a concern. That does not mean I don't support the effort. I just wonder about how useful the data would be on an initial basis for us to use. I'm not the right person to talk about future impacts of TEFCA or fire, so I can't comment on that.
So with a great discussion that's been going on here, what I'd like to do next is tee up our poll to the audience. How we'll use the rest of our time together, excuse me, is to administer the poll. And then what I'd like to do is another round of Q&A. I'd like to invite our panelists to react to the poll, and then I'd like to offer up the chance for anyone in the audience to also give their reactions. So what we're going to do here is ask you a set of 3 questions. Anyone at your computer, or if you're not close to your computer, please do get close to it. We're going to ask a set of 3 questions. The first, I'm going to preview them here, and then let's administer the poll. So the first question that we'd like to ask everyone in the audience today, for each of these types of measures that you see displayed here, how would you rank them? How would you rank their value to your state or your territory? The poll will allow you to look at each measure and assign it a value of very low, low, medium, high, very high. The next poll that we will ask you is going to look very similar, but instead it's going to ask you to rate the feasibility to your state or territory. If we can flip to that slide, we'll give the audience a chance to look at what that will look like. So on the next slide, you'll see a preview of the second poll. Can we get the next slide, or is it, let me know if we can't get there.
Sorry, give me 1 second.
I'll keep previewing the trajectory of the questions. So after we ask you about value, we'll be asking you about reflecting on the feasibility of each of these measures in your state. And then the very last question that we are going to ask you really gets to what your recommendation would be. And looking at the same set of measures for discussion, we will ask you to rank them in order to what you would recommend for inclusion in the adult core set. If I don't see any questions in the chat, but we'll be looking at that in case anyone has a question about the polls that will be coming in just a moment. So let's go ahead and get our first poll out. Let's ask our audience to respond to the question of rating the value to your state or territory for each of the measures, the hypothetical measures for discussion here today. Let's get that poll teed up. Okay, I see some responses starting to come in. This is a long poll, so we understand if you need a little bit of time to think about it. And if anyone does have a question about what the question is asking, please do feel free to put that in the chat. We'll keep the poll open for a little longer because we've right now got about a little less than 20% of those on the line answering. So we'll let you keep responding. Okay, we've got almost 50% who have responded, but we'd really like to make sure that we're gathering as many perspectives. So if you haven't responded to the poll yet, please do take a look so that we make sure that your voice is represented in this important question. The question again is, how do you value each of these measures in your state or territory? Okay, and I'm just going to start reflecting on the responses that we're seeing, so that we can give those who haven't responded yet a little bit more time. So, taking a look first at are the results also showing for everyone? No, okay. Zoom moderator, remind me, if we display the results, does that close the poll?
Unfortunately, yes.
Okay, okay. Then let me ask this, because I would really like to get more opinion. Is anyone who hasn't please raise your hand if you have not been able to answer the poll, but you would still like to. Okay, all right. Well, it looks like we're holding stable at about a little over 50% of responses coming in. So, so here's what we are seeing. We can close the poll so that our audience members can see. What it looks like is that there are folks who have responded to say that the value of a universal screening measure is certainly there, and that it is a little higher for Hep C than for Hep B. And then when we start to look at a screening measure that would add the link to care for treatment initiation, what we see is that we see that trend hold, and that there really is that there's an interest in Hep C over more people responding with value to a screening plus treatment initiation measure for Hep C. And then when we get to the outcomes measure, thinking about an SVR response for Hep C, it looks like whereas we had 64% saying that they would value a Hep C measure on screening and linkage to care, we have about 26% saying that they would rate the same measure with a very high ranking. So lots to start thinking and reflecting about there. Let's go ahead and fire up our next poll. This next poll is going to ask you not about value, but about feasibility. So really think about the available data that you have now in answering the next set of polls. And we'll get the poll up for you in just a moment. Zoom moderator, do we have the poll ready to show? I may just not be seeing it.
It's up, Nicole.
Okay.
Nope, wait, nope, it's not.
Sorry.
Thanks everyone for holding tight.
Yeah, on my end it says that the poll has been launched, but it looks like this might be a Zoom technical issue. Let me see what we can do with this. Apologies on this front.
All right, thanks everyone for holding tight.
So as we're waiting for the poll to pop up, there we go. Again, for feasibility, we are thinking about, is that data available and available in the time frame that you would need to be able to capture it and use it for measurement?
Thanks, Edna. All right, so we do have the feasibility poll up now. Let's see what kind of responses we get. Looks like the numbers are starting to appear.
And Rachel has her hand up. I have opened your line. If you have a question, Rachel.
I have a clarifying question, which is, are you saying would be feasible to collect these data within the state Medicaid program? Because just to the point earlier that Emily was talking about, you know, we are getting negative RNAs, but for us to feed that back to Medicaid to be used into a measure set, the feasibility would be very low. So I think I feel like everybody really universally said they want to use claims and they don't want to have to do all the data matching and everything because it's just too complicated. So I'm just wondering if there's any parameters around feasibility in what universe, like in claims data alone, in Medicaid alone, if there was a collaboration between Medicaid and public health, because it does actually kind of, you know, influence whether it's feasible, you know what I'm saying?
Absolutely. And I'm glad that you asked that clarification question. So yes, please do answer that question if you consider your current state right now with the setup that you have. How do you rate the feasibility of each of these types of measures? Knowing that there are, you know, there's certainly in the Medicare program, we're able to capture similar outcomes measures with the data there, but that at this point, the way that the outcomes measure is set up, it would involve a mix of administrative and clinical data. Tell me if that answered your question, though.
Well, there's also a comment in the chat from Lynn that I agree with, which is that the way that the question is phrased right now, there are a number of options that say linkage to treatment, and we have found that measuring linkage is very slippery. But I think, like Emily said earlier, if, you know, either a prescription was written or it wasn't, and linkage to care itself is actually a completely different intervention that sometimes does or sometimes does not lead to treatment initiation. And so you might want to rewrite this question, honestly, to be treatment initiation, because I think, like, because linkage is often like attendance at their medical appointment. And it's like, well, how do you know if they even had a medical appointment that they were supposed to attend? Like, you know, that's usually only a navigator knows that, not like there's no claim for having made an appointment and then not showing up to it, you know?
I answered it like Emily said. I assumed that it was treatment initiation.
Right. And Nicole, I believe that is correct. That's what we've been talking about the majority of the day. When you really get into treatment, you are looking at usually more advanced outcome measures. We're not talking about there here. So it would be the initiation of treatment.
I do want to jump in and respond. When we're talking about hepatitis C, we're talking about treatment initiation. But since we know that not everyone who has hepatitis B needs to get treatment, that is where we're talking about linkage to care. And we haven't actually had an opportunity to discuss what data is feasible to assess that linkage to care for Hep B. Hope that clarifies.
Yeah, thank you, Jessica, for doing that. I think what's really important is that if there are as we think about these concepts and how they relate to Hep B versus Hep C, for the observations raised, please do make sure that those comments are embedded in the chat, because all of the feedback that we're getting, whether it's in the poll or whether it is through the chat, all of that will be taken into consideration as we write this up. So if you have that concern about how you would operationalize a data element around treatment initiation versus operationalizing a data element around linkage to care, please do put those questions, those observations, and your experience in that area in the chat, because we'll be able to capture it. All right, so I'm trusting that with the amount of time given to this, that we've had enough time to vote in that poll. So let's go ahead. Will anyone who needs more time raise their hand? Let's go ahead and take a look at the feasibility poll results. We had a little lower response to that, but it's okay if some of that relates to confusion. Again, there I'll represent, or I'll encourage everyone to put their comments in the chat. It looks like for our screening measures for both Hep B and Hep C, we have folks generally saying that those measures would be high in terms of the feasibility. We have about 50% saying highly feasible or very feasible. But then as we go down and we start to look at the measures that are related to outcomes, I think we're seeing what we expected, where the more outcomes-oriented measure would be more challenging to answer there, or more challenging to report. Let's go ahead and fire up the last poll. Okay. So the last poll that you're seeing now asks you to give an overall assessment. And we are getting responses in. We have about 6 responses so far. All right. All right. So we have about 20% of folks voting. Let's give just a little bit more time before we turn it over to Jessica to close us out for today. I'll note, just while we are giving folks a little bit more time to respond to the poll, that all of this input has been so helpful. And what we'll be doing in the coming weeks is taking a look at all of the input provided, so that we can make sure to capture it and allow the OIDP team here to consider its next steps. So if there is any additional feedback you are looking to provide, please do make sure it's in the chat, or please do raise your hand so that we can take all of these opinions into account. They really do make a difference, and they really do have an impact. We've gotten a little higher. We have, I still do see the results climbing up. So let's keep this poll open a little longer. Okay, it looks like we may have stopped with about 40% of participants having voted. Does anyone, please do raise your hand if anyone would like more time. Okay. Okay. It looks like we're holding steady at just under 40%. So let's go ahead, we'll close that poll out. And everyone can take a look at what was provided. It looks like the audience, so when you're looking at the results on your screen, what you'll see in the blue is what you see in the blue on the left side of each bar chart is how many people ranked one of the measures here as their top choice. So what you can see in the blue, the light blue and the dark blue again is the proportion of folks who wanted to have their first choice be reflected in a universal screening plus link to treatment measure for Hep C. A little less on the combined Hep B and Hep C link to treatment measure. All right. With that, we can keep the results live here. But what I'd like to do is thank our panelists again. You've all been so terrific in offering these insights. And I'd like to welcome Jessica Deeren back to offer any closing reflections. Thanks, Jessica.
Thank you. Next slide. So let me echo Nicole's sentiment and really thank all of our speakers, our panelists, all of the participants who contributed to the chat, to asking questions, to providing your feedback. This has been a really, really robust conversation, and we wish it could go on longer, but I think 4 hours has been long enough. So we welcome continuous conversation. Let's go to the next slide. Continuous conversation. Here are different ways that you can engage with us. You can join our listserv if you haven't already to get periodic emails from us. Follow us on LinkedIn. Follow us on our website. So we will be posting the slides and the video recording on our website. And you're always welcome to email me. My email is there to continue to engage. So let me talk a little bit about next steps. So we will be taking a look at all of the ranking polls, reassessing, what the feasibility and value is, what the consensus has been, and it sounds like we are coalescing around a certain measure. We'll take that into account before moving forward with selecting a specific measure. And the next steps really are to identify states that are willing to partner to test these measures within their states and validate that validate that measure within your state before we can really move forward to proposing it to the Medicaid adult core set. So this is a long process. This is the first step. We're just generating national consensus to identify a measure that we can propose to the adult core set. Next, we'll have to identify states that are willing to partner to test that measure and validate it. And then we can put together a proposal to the adult core set. So more to come. Please continue to have the conversation. I know that there's still open questions on potential hepatitis B data sources. So we are always open to have an open line and continue to engage. Let me see if there's anything else next. Any other slides? No, so that's it. Thank you again so much. Thanks for everyone who stuck around for 4 hours, and we'll continue to have the conversation. This concludes the technical consultation meeting today. Thank you.